Good afternoon, everybody. My name is Ruth McEwen and I'm the Chair of the Health and Wellbeing Board. Just before we start, I have an announcement. I would like to inform everybody present that this meeting will be recorded and broadcast live in Microsoft Teams and will then be uploaded and available for repeat viewing on the Council's website. You should be aware that the Council is a data controller under the Data Protection Act. Data collected during a webcast will be retained in accordance with the Council's published policy. I'm afraid that due to current technical limits in the Council chamber, not all members of the board physically present will necessarily be able to be seen on the camera, but you should be able to hear everybody if they use the microphones. The seating in the public gallery will not be filmed. Members of the public are only able to speak if they've submitted a formal question in accordance with the Council procedural rules. Please could councillors, officers and partners attending introduce themselves before they speak at the meeting for the benefit of the public. And just to help me manage the meeting, if any members of the board attending online wish to speak during the meeting, please can you indicate your wish to speak by raising an electronic hand in Teams and also verbally. Those members in the chamber can indicate their wish to speak by raising a physical hand as usual. When not speaking, all online attendees should put their microphones on mute and switch off the cameras. If called to speak, please switch on your camera and unmute your microphone and pause for about 3 seconds to allow for a slight time delay in connection. Thank you. Thanks very much. So moving on with the agenda. So agenda item 1, any declarations of interest?
You just name someone. Those nameplates should be yours.
Immediately in front of what you're about to say.
Perfect. I thought it was a... Oh, right. Yes, Councillor Buck.
In respect of item 5, I'm the chair of the Bob Integrated Care Partnership. It's a non-pecuniary interest, so I won't recuse myself. And because the Integrated Care Partnership is a joint board without any independent finances, it's also not a financial interest for the partnership.
Thank you, Councillor Brock. Any others? No? Okay, thank you. Agenda item 2, minutes of the meeting held on the 7th of October. Is everybody happy to approve the minutes? Happy with the minutes? Yep. Okay, thank you. Agenda item 3, questions. We don't have any questions. And moving on, petitions. We don't have any petitions. So we'll move on to agenda item 5, which is developing the Bob Integrated Care System, and we have Sarah Webster. And I think Tracy is online. Tracy Dakovic. So thank you very much.
Brilliant. Thank you very much, Chair. So for this agenda point, there's been a lot of information shared in advance, and I wasn't proposing to go through slide by slide. I think we've all heard a lot of this in multiple forums as well. What I will do is provide some background and context to this agenda item. Yeah, let me move it closer. Is that better? Yeah. So I will provide a bit of background and context to this item, and then we can open up for discussion and questions. So as Councillor Brock has already mentioned, we are all now part of an integrated care partnership that spans Buckinghamshire, Oxfordshire, and what we refer to as Berkshire West, which is a collective of Reading, Wokingham and West Berkshire local authority areas. The partnership is here to do many things, but the crux of it is to bring together NHS and local authority organisations so that we can better integrate our services where we're directly providing care to our populations, and we can better join forces so that we can work together to overall improve the health and well-being of our populations. That's the crux of why we now have a partnership way of working across this broader geography. Locally, we're still working very closely in what is called the Berkshire West Place, which is the collective of those 3 local authorities plus the NHS organisations within Berkshire West. So it's a very, very key part of the kind of the system, the way of working, and making sure we still have a very local focus here on our local population needs. So as an integrated care partnership, an awful lot of work has gone into kind of setting a strategy. What are the areas that we really want to come together, where we can see by working collaboratively, we can make the biggest difference on behalf of our residents. And the strategy has been developed over the past few months, and the document in the pack is a summary of what is currently the draft strategy. And we are out to consultation about this at the moment, and it's seeking engagement from everyone. So it's public engagement. We really encourage everyone to feedback their comments and views on what are currently the draft priorities. It's been built from health and wellbeing strategies. So here in Reading, in partnership with our Wokingham colleagues at Wokingham and West Berkshire, we have our joint health and wellbeing strategy, and the ICP strategy is very much being built up from the existing health and wellbeing strategies. So there shouldn't be anything surprising in there. They're all very, very much aligned to the health and wellbeing strategies. So the proposed priorities have been grouped into 5 areas around promote and protect health, start well, live well, age well, and improve quality and access to services. Each of those areas has a number of sub priorities that we'd want to work on together as a partnership. I don't propose to go through all of the detail of every single one here in my presentation. Colleagues have had the chance to read this in advance. So really, I'd just ask Tracy if there's anything that you wanted to add to this, and if not, I'd open up to questions if that's okay, Chair.
Thank you, Sarah. Tracy, did you have anything to add?
And the only thing good afternoon, everybody. Tracy Daskovich, Director of Public Health. The only thing I'd add is, in terms of pulling this together, there was a series of thematic specialist working groups that come together. So it is formed from the expert input from a range of professionals. So there was a lot of background, a lot of work done to this that is drawn on from a range of partners across the system within the 6 themes that Sarah has outlined. Thank you.
Thank you, Tracy. I'd like to open it up to questions or comments. Has anybody like to raise any questions?
Say something about the meeting you had last week. Feedback that's in the.
Yeah, I mean, obviously, we met last week and discussed and there was some very good feedback from and going through the priorities. I was, just thinking about the recurring theme that's come through is reassuring residents of Reading, really, that their voices will be heard, and it's all about the place. And as Councillor Brock has mentioned in the document as well, that the areas of Reading that are where there's higher levels of deprivation, and how people within Reading will be heard within the huge sort of the Bob area. So just to expand on that, and just another thing, when we're talking about engaging, how are we about work that would happen with, possibly people within, like care settings, and what work's being done to engage with sort of digitally excluded people?
Thank you. So on the first point around how do we make sure we still have a local voice in this, I think the one way to describe it is that the strategy kind of sets a macro direction. So where do we all think is the right direction to be, right direction of travel across the broader geographical footprint? Within that, there'll be areas that are more pertinent than others to our people in different wards, down to kind of a ward and neighbourhood level. And from in Reading and in Berkshire West, we've got a partnership that kind of mirrors the membership of the Integrated Care Partnership at a BOB level, here more locally in Berkshire West. And within that, we've been having some conversations around, and how do we make sure then we retain a focus on the 3 local authority areas and wards within that. So there's absolutely a commitment that we need to do that, working with colleagues in primary care at PCNs, and making sure that where the strategy sets the broader direction, the action plans and implementation need to reflect the needs of different pockets of our population, because everywhere is slightly different with different needs. So it allows for that level of agility. In terms of the broader engagement, I think what might be helpful is if we circulate a schedule of exactly what engagement events are planned or taking place. Colleagues from the voluntary sector organisations have been involved in the development of this, and from care organisations, but there are also a number of kind of physical and virtual drop-in sessions planned. So I can circulate that information with the notes from the agenda, and we can make sure that is public as well.
Councillor Ennis.
Yeah, thank you. Thanks for that. Thanks for the presentation. Very much welcome the objectives. We took part in the as lead councillor. Should introduce myself. I'm John Ennis, lead councillor for adult social care. Currently suffering from COVID, so I'm online. We took part in the consultation, and we very much welcome the objectives and the plans. I mean, some people see this as a challenge. We see it as a challenge that we're more than happy to be involved with and work with our health colleagues in making Reading a better place. We do want to reiterate, because we're part of the scrutiny panel as well, myself and Councillor McEwen will hopefully, health pending, be attending the scrutiny meeting next Wednesday in Aylesbury. But we really do want to reiterate the issue of health inequality. It's a massive issue nationally and locally for ourselves in Reading, and we want that prioritised as much as possible, because Bob is a very big area with very much differing types of health and wealth inequalities, where some areas would be 10 years better than places in the urban areas, and that's a priority for us in Reading, because we do like the need, making sure meeting the need where necessary, and we feel that Reading has got some very acute needs that need to be addressed and met with. We also would like to use ACE, our Adult, Children and Education panel. It's a panel, not a scrutiny panel. It's a panel committee that we met on Wednesday, and it was great to see health there, giving a really good update on what's going on. To use that to also scrutinise at a local level, because it's so important. So I very much welcome working with health colleagues and looking forward to attending the scrutiny meetings and seeing how the progress is made in a very challenging environment at this moment. Thank you.
Thank you, Councillor Ennis. And I can see Alice is online. You wanted to speak?
Hi.
Okay.
Hello. Hello. I'm Alice Clifton. I'm the lead officer for Health Watch Reading. Just to also reassure you guys, the councillors, that Health Watch is also at the table at the Bob ICB. So we also will put out the public voice of the public needs as well. So be assured that the public's voice will be heard at Bob.
Thank you. That's really good and reassuring to hear. So thank you. And sorry, going Councillor Hoskins. Sorry,
thanks, Chair. Yeah, I'm Graham Hoskins. I'm lead for children at the council. I'm basically what John said. I'm not going to repeat that. I agree with everything he was just saying there. I think well, one of the challenges, one of the concerns we always had would be about the voice of Reading as a relatively small place within the ICP. So it somehow passed me by that our leader had become chair. So well done. That's congratulations. You won that sort of Game of Thrones to secure that position. But that is actually really important in terms of influencing the direction. I mean, in terms of the document, I think this is a good document. It really improved from sort of the early drafts, which suggests that there's a listening process going on. I think one of the challenges, which I think perhaps it was John that alluded to, is that to really address the health of an area, the NHS is actually quite marginal to that. People's health is much more influenced by their jobs. It's in the document: housing, inequality, opportunity, and empowerment. So I think in order to achieve some of the objectives around reducing health inequalities and improving health outcomes, particularly, in places like Reading and Oxford that have got the largest sort of pockets of inequality and areas of worse health outcomes, does require action right across the board, and unfortunately requires action from a lot of the areas that have been most suffered a lot of budget cuts over the years. So councils used to do a lot of stuff around community development, youth services, a lot of stuff out there which they just don't do anymore. Public health budgets have been slashed year on year. I think they're sort of stabilising at the moment. But I think there was a real terms cut, wasn't there? So there's a really worrying sort of context of this. And of course, we don't need to mention the struggles that the NHS has got in terms of what's been inadequate funding for the last sort of 12 years has led to some of the and lack of staffing and all sorts that's really leading to issues within the NHS. So I suppose what I'm saying is that it makes that what we do here locally within the area more important than anything. So to add on to what Jason said, I think John said, or am I supposed to say councillor or anything? I'm not quite sure how formal I'm supposed to be. What will be really important is how strong the area representation of the local NHS is and what power they've got to work with us and community, voluntary sector partners to really deliver on these objectives. Because without that capacity in the area, I think it'd be really difficult to deliver on this, even though we might have Jason as chair. Just the fact that you and John are going to go to a meeting in Aylesbury just demonstrates the craziness of the geography. I grew up in South Bucks. So I knew virtually nothing about Aylesbury because it was like the other side, almost never went there. So it's some place that we know little of and care even less, quite frankly. But somehow we all need to come together to deliver on this. So big challenge. I think just emphasise that local capacity to within the NHS to deliver on this will be vital. Thanks.
Thank you, Councillor Brock.
Thank you, Chair. It's good to know Councillor Hoskin listens to me when I ramble about being chair of the ICP at every group meeting. But I think, as the only Labour councillor on the body, I suspect I was just a sort of quaint novelty who therefore ended up in this wonderful position. But a very interesting body, and there are some very genuine opportunities to be found in the sort of integrated care system setup. And we will best have an opportunity to potentially realise those if we are an active participant and a sort of meaningful partner in the process as it moves forward. And I think you can see that there are probably some other elements of the partnership who are more interested in being slightly obstructive and have issues with the process. And I understand those concerns, but we have to deal with the world as it is, not always the world as we want it to be. So I think the strategy is something that we should engage with and we should respond to. And as a council, we will provide a response independent of this here at the Health Wellbeing Board. Although, I would be interested to hear, Chair, if some of the partner members of this board have views that we might then be able to feed in, because the council response is going to be on behalf of the council, clearly, but there might be a place for the Health and Wellbeing Board as a partnership body locally here in Reading to express its own view also. But I think that's all I have to say. No, apart from one other very important thing, which is that throughout the ICP and the ICB, the Integrated Care Board, have accepted the principle of subsidiarity and of trying to take decisions as close as possible to the people who are affected. So that means that within our expansive geography, actually the place-based partnership at Berkshire West level, led by Sarah over the other side of the room, is going to be more important than perhaps place-based partnerships might be in some other ICSs elsewhere in the country. So it's a good thing for us, keeping things at place level and therefore closer to Reading. Though I entirely accept the points that Councillor Ennis has made about the fact that Reading, as a large and densely populated urban area with particular challenges around inequality, does not always look exactly like our near neighbours in West Berkshire and Wokingham boroughs. Thank you, Chair.
Thank you, Councillor Brock. And Sarah Webster want to speak?
Yeah, thank you. And I realised I didn't introduce myself at the start. So I'm Sarah Webster, the Executive Director for Berkshire West on the Integrated Care Board, which is now the NHS commissioning function within Bob. And actually, I think Councillor Brock's answer said most of my comments, just in terms of reassurance around that real local voice and the local partnership that we have here. And I'm working really closely with Melissa and colleagues in the local authorities to make sure that we feel like we do have that strong unity as partnership, and that we're working as closely together as possible. In terms of the financial challenges that we're all acutely aware of, I think that's one thing that working as a partnership can really help to unlock some of that. Where are we duplicating? Where aren't we streamlined? Where can we make better use of the Berkshire West pound, as we've historically referred to? So I think that's a really good opportunity for us to come together to address some of those challenges in partnership.
I'm just looking around. Was there anybody else to speak? No. Okay. Well, thank you very much for that, for contributions. I think it's obviously we welcome the report, and everybody's reiterated the importance of place and of Reading having its voice heard within such a large organisation. So there was obviously a lot of work to do, but I think it's a very positive report and lots of work to be done. But thank you very much.
Chair, just the document that Tracy produced that's in the papers.
Yeah.
In terms of producing a response from the Health
Health and Wellbeing Board.
Could you just get the board to agree maybe that, because Tracy's going to be leaving soon, that Melissa could, as the exec director, could create a response to go back to the ICB on the draft strategy?
We agree it as a sort of, I can move it if you need, to delegate to the acting executive director for adult social care in consultation with the chair of the Health and Wellbeing Board that a response is prepared. Someone had better second it.
Well, that's very sensible.
So Councillor Hoskins, a second. Okay, thank you. So that response will be prepared by yourself, by Melissa. Yeah. Yep. Okay. Thank you. Everybody in agreement with that? Thank you. Okay. Well, thank you very much. Moving on then. Thank you for your contributions. So moving on to agenda item 6, which is the Western Berkshire Safeguarding Adults Board annual report, and Keith Brown is here to present. Thank you.
Hello. So my first visit to you here at this board, Professor Keith Brown. I chair the Western Berkshire Safeguarding Adults Board. Just a bit of context. I also lead the National Research and Work into Fraud and Scams on behalf of Economic Crime Unit, and I chair the NHS England National Safeguarding Board. So you have the report. Not really sure whether you'd just like to take questions or whether you'd like me to make some observations about my first year here with you, or how you'd like me to best do that. I was certainly keen to come and meet folk and to introduce myself. So.
Well, do you want to give a quick overview of the report?
Okay. So one of the roles of the Safeguarding Adults Board, as you're probably aware, is to undertake safeguarding adult reviews. We've had 6 in the reporting period, which is about normal for a board of this sort of size. One of our areas of determination this year for development is to introduce what we are referring to as a more rapid review process. Safeguarding adult reviews can take 1 to 2 years sometimes, which seems to be an inordinate amount of time to get the learning out from a tragic event. And so we've been doing quite a bit of work looking at a rapid review process. There's a limit to how rapid one can be while still being thorough. And we're hoping to bring some of our timelines down so that in certain circumstances, we can get results out of a SAR within 6 to 9 months, which is kind of an area that we're kind of working across on the country on. Here is no different to many other parts of the country, that most of the concerns around safeguarding in some shape or form end up forming around the Mental Capacity Act, or a lack of understanding of the Mental Capacity Act. You see the terms in our report here about citizens and residents with self-neglect. Self-neglect can include a whole load of things, can't it? Hoarding, behaviours that we might perceive to be harmful. The issues here are, should we be allowing people to make an unwise decision, or do they not have the capacity to make an unwise decision? And that kind of binary issues around mental capacity. Do you have capacity or not have capacity? And a realisation it's far more nuanced than that. And we need to start much greater understanding, in my understanding and view, as to the executive functioning that's going on at the time, whether people in that actual position can actually make a self-determined decision or not. These are just national issues that we're trying to promote and push through as a board. The other thing I'm quite keen on as a relatively new chair, still been with you now for 9 months, I think we've got a very strong board here in terms of agency involvement from the main welfare state agencies. I think we don't hear on the board as well as we could from the community. Now, I don't mean users and voices, we hear that, but I think we can sometimes forget that quite a lot of services, things like food banks, provision of support to lonely older people, provision of support to homeless people and people on the margins of society, often are delivered through faith-based groups, community groups, smaller action groups, and boards are often much less cited as to the activities of those groups. So it would be one of my intentions in the next year or so as the board to make sure that we have better mechanisms to hear from the non-standard welfare state services, if that makes sense. I think I'll pause there perhaps and take any questions.
Councillor Brock.
Thank you, Chair, and thank you for your work, Keith, and the work of the board in general. I mean, it's really important. It's an important area where it's obviously fundamental that the council engage with safeguarding reviews, that we're transparent and discursive around them, that we seek to learn as we move forward. So a couple of questions in particular. Well, one comment really. Comment is there is some trends data provided in the report.
Yep.
It'd be quite helpful to have that broken down by local authority, because as we've already alluded to today, clearly Reading's demographics are somewhat different to West Berkshire and Wokingham, so understanding what might be playing out in Reading would be helpful. I'm not saying you'll have that with you now, but it'd be helpful perhaps if next year we might be able to disaggregate. The question relates to the very substantial increase in safeguarding concerns actually across the patch, but most prominent here in Reading in the 21-22 year. Now, clearly that hasn't led to a large increase in inquiries, formal inquiries to safeguarding, but nonetheless a lot more expression of concern about individuals. I see that you've got a sort of part of your action plan is around how to deal with this, understand it, overwhelms us internally, overwhelms other local authorities as well. But do you have a sense of what might be a causal factor there, or factors? Why has there been such an increase?
Absolutely.
It's really marked.
Always ask a professor. Yes, exactly. I do. So a couple of observations. I think nationally, the data is very similar. There are more and more inquiries raised. I think sometimes that is because people are just not sure where to raise an issue. So just in case, they raise it as a safeguarding concern. So there's a bit of education that's required to help people understand what is an appropriate referral and what is not. However, let me try and explain it in this terminology. When I first started my work after I left paediatrics in the 80s, we just started to do away with the term a non-accidental injury and introduce the term child abuse in 1979, 1980, but that was solely for physical assault. It was a number of years before we included the term child sexual abuse, and then a few more years before we started to think about child emotional abuse. And so what I'm trying to suggest here is over years, the term child abuse got bigger and bigger and bigger and encompassed more and more things. And I think the same thing's happening with adult safeguarding today. We're still in the middle of a growth of an understanding as what is adult safeguarding. For example, we only recently just had the domestic violence bill and domestic assault stuff coming through. So it's not unsurprising that we're getting more concerns and more referrals, because society's understanding of what might be deemed to be an adult safeguarding issue is getting wider. Does that make sense? It's no longer just, has an elderly person got a bruise on them? It's much more nuanced and much more subtle than that. And let's be clear, if criminals carry on at the rate and speed in which they're undertaking fraud and defrauding us and scams, we're going to have, you know, a massive mushroom. So it's not just about the demographic area of which part of the council is it, and whether it's a richer, a poorer. In fact, you could argue that the most wealthy areas like Wokingham are being targeted by criminals more actively than the poorer areas in the forms of scamming, because they've got more to gain, because they've got wealthier people to scam. Does that make sense? So it's not classic here. It's not the classic, the poorest areas have the biggest problems. The oldest, are you with me? It's a big area that's growing rapidly, and I suspect will continue to grow and continue to be a major issue for you as councillors, unfortunately. Does that answer your question?
It does. I mean, I suppose it maybe begs a further question, and is the term safeguarding sufficiently precise to be useful? I mean, if we allow the term to become sort of more and more encompassing, increasingly voluminous, then we cease to kind of have a definition around what it is and what we're trying to grapple with. And that's important culturally within and between organisations, as well as in the broader public mindset. But it's this sort of particular spike in Reading, I suppose, increasing from 1,367 safeguarding concerns in 20 to 21 to 3,067 in 21-22. So even within the context of that broader sort of comprehension of safeguarding, which I think you're absolutely right. I think there is that journey in terms of what's happening. But there's a particular spike, which may transpire to be a statistical aberration, but it may not. And I suppose I was looking to if there's anything that, and Melissa may also be well placed to offer some thoughts on this, anything in particular locally that explains that, because clearly a lot of it transpired to not be legitimate safeguarding inquiries, because those numbers have not changed all that much in that time.
Do you want to answer first and I'll come back in? Or
Over to you. Thank you.
I mean, really very valid points. Was one of the reasons why I was very keen to actually come here today, because I think increasingly safeguarding adults boards need to work and align themselves with health and wellbeing boards and with community safety partnerships. Because as you're rightly saying, if we're not careful, this term safeguarding becomes so broad, so wide, so tall, it's encompassing everything, and we need to decide actually where is it appropriate to deal with it. And when is it a community safety partnership issue? Often fraud is. When is it a health and wellbeing board issue? Many of the issues are. So I take that on board. Coming back to your comments about the numbers, I come back to my comment. I think we have had a spike of people in the last year or so, particularly coming out of COVID, just not quite sure, and therefore overstating levels of concern. But I think that we mustn't just pretend that's the only cause. There is a definite going to be an increase, I think, over years of more of this activity and more genuine concerns. Yes,
Thank you, Melissa.
Thank you, Chair. Oh, and you, Keith, because I totally agree, and I think we welcome it, and I think we're all saying the same. Actually, the more visibility of this, the better, and it's just helpful to understand the statistics. I think there isn't a particular Readingism in this, beyond what Keith's saying. I do think there is something about education, about what safeguarding is and isn't, and I think Reading have had we've probably got a longer journey on that, because a lot of what we're seeing isn't safeguarding, which we've talked about. And I think a product of that is Reading's process has been very open and wide. So we make it very easy, which is the right thing for people to come to us. But what we've introduced in the last year is things like a professionals line, for example. So rather than submitting a safeguarding referral, you can have the opportunity to talk to somebody to tease out whether it is actually safeguarding. And we've also now channeling all of our front door for safeguarding through our customer call centre corporately. So I think we're doing some work to make sure it's streamlined and we're capturing safeguarding and also giving opportunities, at which I think the others had done different things, but at an earlier point. And then I was just going to mention the obvious pandemic nature, and people have become more concerned because there hasn't been the eyes on services in the way that there was pre-COVID. So I think it's a combination, but I think Keith's point about going forward, us seeing a continued increase is absolutely right, and we need to think about our resources, about how we manage that internally, and equally look at that across the board about themes that we're seeing.
Just to assure you also, it's not in the report, but my other area of concern for this year, and it's not just here, it is nationally across all boards, is a safeguarding concern with staffing numbers. If care providers are really struggling to staff, there's often going to be a potential quality of care safeguarding angle to that. And I think one of the my biggest anxiety is not necessarily here, but somewhere, who's going to be the organisation that wakes up or on a Sunday gets the phone call to say that the local domiciliary care agency's closed down, or the care home is just shut because no staff have turned up. Now, at least if we know if it's a care home, we know where that is and we know who we've got to care for. The real anxiety if it's Frida Smith, Joe Blogg's domiciliary care agency, and they shut down at 9 o'clock on a Sunday and they've got 200 clients on their books. How do we ensure that they're put to bed that night, fed, cared for the next morning? I mean, our systems are at breaking point in some of these areas, aren't they? And staffing and that crisis. So I'm just sort of assure you that as a board, we are trying to ensure that we are asking for mitigation plans and plans of action to cope with those sorts of things. And I think increasingly we're going to have an eye to that level of potential system failure. And the problem will be, it won't be, as I say, it won't be the large welfare state body that breaks. The council won't topple over, I hope, or the health hospital won't topple over, or the ICB won't topple over. But some of those provider units in the private sector could topple over.
Thank you for that, Keith. Councillor Ennis is waiting.
Yeah, no, thank you. I don't think I'm going to add anything majorly new, but I think it's important to report through that to thank Keith for the report and thank Keith for his work since he started leading safeguarding adults on the board. That we had our meeting of the Adults, Children and Education Committee on Wednesday, and this report was brought through, so it's had its political discussion through local councillors, and much of what's been discussed was raised there. I think we are, it's a relatively new phenomenon, safeguarding adults and reports of adults. Children has been on the agenda for a few decades now, and adults is really just coming to the fore. And I think in some ways the law may be behind in some ways, but it's increasing because as the population gets older and people become more vulnerable at an older age, abuse can take place within the family and without, is the issue, is a challenge. Two of the issues that were raised were making sure that everybody, no matter language, culture, ethnicity, gender, it doesn't matter, that everybody has the opportunity and the knowledge to be able to report. So in some ways, having lots of reports in isn't necessarily a bad thing, because we were concerned, some of the figures that may be harder to reach groups, or some families or some individuals would struggle to report. And that's something we've sort of focused on in Reading, to ensure that everybody has the knowledge, everybody has the ability and the confidence to be able to report abuse, potential abuse. And then I take it the challenge will be for adult social care safeguarding, and it's similar to children, is to triage in some ways what the reports are coming in, because I know in children there's been an issue where some of the reports haven't turned out to be to hit a threshold, and there's been a lot of time spent on tracking people that didn't need tracking, and we've missed people who did. And that's something that we have to be mindful of here as well, is that we don't want to be engulfing adult social care safeguarding and our partners with, and this is for the agencies as well, with referrals that didn't meet the threshold, whilst we're missing those. And Keith, you made it your point about the care home or a carer abusing someone, in their care in the dead of night, and no one knows. And I think that is the challenge we're facing. But I do feel that it's a challenge that we've got to meet, and it's something that we are going to meet on the way, because we have no choices in that. So certainly the ACE committee were very much welcoming the report and working forward with it, talking of Reading in West Berkshire, to ensure that we can see the numbers going up and the thresholds that are being met and are being dealt with. So thank you.
Thank you, Councillor Ennis. Oh, is there anybody else to speak on that? Oh, sorry, Steve Hatfield. Thank you.
Yeah, thank you, Chair. Steve Ratfield, I'm the local police commander. I just want to touch on a point that Keith made. I think that interaction between adult safeguarding boards, children's safeguarding boards, and the CSP actually is something we shouldn't underestimate. We've already touched on, kind of localising place-based plans, and I think there are some specific problems in Reading that mean we have to make sure that interaction between those groups is really good. So we've got a meeting coming up just to talk a little, just to reassure the board. We've got meetings in place to talk about interaction between CSPs, the various boards that are in place, and also the combating drugs piece as well.
Dr. Andy Czerski, GP and Vice Chair of the board. Keith, thank you for the report, and was interested in what you mentioned earlier on about the challenge of older patients who may be on the verge of lacking capacity, that potential of self-neglect, hoarding, all of that. I mean, just as an example, I work with a multidisciplinary team in my area, and there's been a number of clients, patients, residents who have been in that exact situation. And I can almost see the car crash coming, but there's a difficulty sometimes of people, we can all see it coming, but there's a difficulty understanding which agency can actually help when there is this capacity issue. And some people are reluctant to say a person hasn't got capacity when I know quite clearly they don't have, or they've even been diagnosed with dementia. At what level is that capacity then need an intervention to support them? You mentioned this as a national issue, and it's a sort of an ethical, philosophical discussion, because I don't feel as a doctor I can force myself on patients to say you have to do this, and I can see that also the council, adult social services, can't always do that as well. So we have these interesting discussions of how do we think about the well-being of our patient, resident, our client, to try and prevent that potential car crash coming, which I hope are not some of the cases that you end up having to review. Thank you.
Yeah, thank you. I mean, I wrote this book last year, Demystifying Mental Capacity, because I got so fed up dealing with these issues to try and move the sector on legally. Because you're absolutely right. If somebody's dementia is so bad, it's very clear if they don't have capacity, we deal with it. You and I, we hope we have got capacity, make the decision. The problem is when people are in that state where they're in the early to middle stages of dementia. And I often quote, in fact, I quoted on the webinar just on self-neglect for your council here just a few weeks ago, my own mother, you could talk to my mother and you'd be convinced that she had capacity. And so therefore, you'd be very easy to say, well, that's her own self-determination. She can do what she liked. But when she got the ham out the fridge, she could read the readings, and she could even read what the sell-by date was. but she had no understanding what the sell-by date meant. And she had no understanding that it meant once that date had expired, you shouldn't eat it. Does that make sense? And it's that cognitive issue, isn't it, in that area? Actually, can you make a decision in that specific arena of that time? And of course, that is a very, very murky, very, very muddy and not straightforward. And you can clearly have capacity to make some decisions and not the capacity to make other decisions. Indeed, if you want to take it really far, out of interest, how many people make a genuine informed consent before surgery when they sign the paperwork? Do they really understand all the issues? And actually, many of us in this room don't actually meet that target, do we? We just want to get the operation over with. And so it's very nuanced, and we're going to have to build in a lot more thinking, because you're absolutely right. Those elderly people, particularly lonely elderly people, moving into that period of cognitive decline, we have to support them in far more creative ways. We have to listen far more. We have to find far better ways of communicating with them than we have done hitherto. And that's going to be one of the biggest mushrooms of demand of our time. And so I'm completely with Steve, unless we get the Community Safety Partnership Board and other boards like this together, we're doomed. But I think we are getting them together, so we're hopefully not so doomed. And the other reason why we need to work harder with the Children's Board, of course, is all the transition stuff. You know, and there's too many SARs nationally about issues around transitions as well. So I'm sorry that's a bit of a, not a clean answer. But, you know, I mean, one of the things I'm campaigning for at the moment is that we go back to universities and check the legal literature that's been taught to our professionals coming off the production line. Because there are still far too many SARs nationally where professionals have simply not understood the Act. It's been around 10 years.
Thank you for that answer, and thank you for it's an ongoing challenge for all health professionals as well. Thank you for.
Good afternoon. My name is Eamon Sullivan. I'm Executive Director and Chief Nurse in the Royal Berks Hospital. I think there's a real link between Sarah's paper and Professor Keith's paper in terms of both preparing our community and our carers, but also training the next generation and attracting and training the next generation of health and social care staff, which I don't see in the various strategies. But that's probably the biggest challenge that we're leaning into at the moment is retention and recruitment. And I think we probably have I don't see it in the Bob paperwork. I know there is a workforce plan, but there's certainly I guess it's that there's an obligation for us to open up these career pathways and to be attracting people in at the various earliest ages, because this is something we're all going to have to lean into, be a major focus for us in the next 5, 10, 15 years.
Very interesting in that 2 days ago I was in Worcester at my other board, and they've just asked me to join the ICB Workforce Planning Group for that reason. You know, unless we actually start to think through workforce planning, workforce retention, and making sure we've got the workforce with the right skills, we're in real trouble very quickly.
Thank you for that, Eamon. Thank you. I'm really grateful for Keith for coming today to present the report and raise awareness of the board and its work. Reading's voice is obviously very important, especially for the seldom heard, and it's just interesting to hear the work that's happening and also to know what the Health and Wellbeing Board can do to support the ongoing work. So,
if it's okay, I'll make my leave to go back. But thank you, very nice to meet you all.
Thank you very much for coming. Thank you. Right, so moving on. So agenda item 7 is Reading's Community Safety Partnership, Community Safety Serious Violence Strategy 2023 to 2026, and Reading's Domestic Abuse and Safe Accommodation Strategy. And that's to be presented by Joe Middlemas. Sorry, Joe. Sorry, I've got it here in line. Sorry.
Thank you, Chair. I'm Jane Middlematt. I'm the Community Partnership Service Manager at Reading Borough Council and the operational lead for the Council for our Community Safety Partnership and our Domestic Abuse Partnership Board. Presenting with me today is Superintendent Steve Raffield, so I'll let him introduce himself.
Yeah, thank you. I think I've introduced myself already, but just for context here, so I chair the Community Safety Partnership here, and I also co-chair the Serious Violence Steering Group.
Thank you. So we wanted to come to the Health and Wellbeing Board today just to give some oversight in terms of the work of our Community Safety Partnership and our new strategy alongside our domestic abuse and safe accommodation strategy. So what we wanted to do was just set some context in terms of the role of the Community Safety Partnership and then just give an overview of our priorities for our strategy and plan for the next 3 years. And then I'll move on to our domestic abuse strategy as well. So hopefully colleagues will be familiar with Community Safety Partnership, but just for context, the role of Community Safety Partnerships is a statutory role, so bringing key partners together to tackle and problem solve issues around crime and disorder. So the Act that came in back in 1998 set the statutory duty for partnerships to come together. The council being one of those key statutory partners, along with police authority, so for us Thames Valley Police, but also the probation service, fire service, and what is now the integrated care system as well, so previously the CCGs. For Reading, we bring along other partners for our community safety partnerships, so we have several of our voluntary and community sector partners on our executive group, and we bring in key partners as and when required, depending on the focus of our strategy as well. We do have very strong links across various other boards as well. So with the One Reading Partnership focusing on young people, Reading's Youth Justice Partnership Board, and what we're hoping to do following on from today is ensuring those stronger links between the Health and Wellbeing Board and looking at how we can cross-reference as well, picking up on the conversation we just had with the Safeguarding Adults Partnership as well. So in terms of our statutory duties, the Community Safety Partnership is required to produce a strategy which sets out how we will reduce crime and disorder. What we have to do alongside that is complete a comprehensive strategic assessment to understand the issues in local areas. So for Reading, it's understanding our crime levels, but not just the crime levels, it's understanding the perceptions of crime, what's happening across the partnership in terms of reports that come into them. So for example, the fire service bringing their data into those assessments, as well as what's happening across our housing stock and within our housing partners as well. So it's pulling together a range of information to help us understand from a broader perspective what the issues of crime and disorder are. Also for us, it's really key for us to understand the impact of crime on victims. So really bringing in the voice of victims into our strategic assessments as well is key for us. In addition to the requirements set out for CSPs, the Police Crime and Sentencing Courts Act of 2022 placed a requirement on partnerships in the form of a serious violence duty. So given recent years, the issues around serious knife violence and other associated violence issues, the government's really taken this into consideration and has now placed a duty. For Reading, we've utilised our community safety partnership as that particular partnership group to oversee the work that we do around serious violence. But with that has come similar duties as we have around crime and disorder. So to undertake a strategic assessment to understand the issues around serious violence, but then to go on and formulate a strategy and a plan as to how we're going to resolve and tackle and prevent those issues over a 3-year period. So from our community safety partnerships perspective, we're now in a position whereby over the last 12 months, we've undertaken strategic assessments to understand the issues for Reading. What we have done is combined our strategic assessment to focus on both the crime and disorder element, but the serious violence element as well, because they're so closely aligned. For us, the parallels are very clear. So we conducted a strategic assessment, which was really completed over the summer, and then from that we drew out some priorities that we carried out a consultation on over the summer into the autumn period of 2022. Using the feedback from that public consultation, which is actually one of our statutory requirements as well, to conduct consultation, we then developed some priorities and started to formulate our strategy. The strategy, so Steve will go on to the priorities in a second, but just in terms of process, our strategy was finalised by the Community Safety Partnership in November and adopted by Housing, Neighbourhoods and Leisure Committee, so our scrutiny panel for the Community Safety Partnership earlier this month. So we now have a live strategy document, and Steve will just talk through what our priorities are for the next 3 years, and then we'll talk through kind of the delivery mechanism. So I'll hand over to Steve.
Thanks, Jo. So our combined priorities over the next 3 years: reducing crime in our top crime-generating neighbourhoods, improving the way that the CSP works to tackle antisocial behaviour and hate crime. Something that's come back quite strongly is around hate crime and the way we investigate. Reducing community-based drug-related activity, a fairly broad priority. What's going to be important here, and something I touched on earlier, is how we interact with the Combating Drugs Partnership in this space. And then something which I hope everyone understands around knife crime, carrying of knives, and their criminal use. And then tackling the organised element of crime involving gangs, counter-drugs lines, and organised crime groups. And adopting a kind of data-led approach to this as well. Those most hurtful drugs lines is especially something we're keen to tackle and deal with. And then something also very topical: improving safety for women in public places. We've already done a fair bit of work in this space as a partnership. Developing a strategy to reduce persistent reoffending, and then something which we all agree we're very keen on, and I know a number of you will also agree with this, the communications and engagement piece, which I think over time we've probably lost our way on a little bit, and we want to be really clear as a partnership around how we listen to and engage with the public and report back around what we're doing.
Thanks, Steve. So within our strategy, what we set out was how we would approach the delivery of the strategy, taking on board best practice from other local areas, but also guidance from the government as well, particularly around the serious violence agenda and the guidance that's come out to local areas around the serious violence duty. So there's a real focus around a public health approach, particularly in relation to serious violence. So really underpinned by the World Health Organization's definition of a public health approach to reducing violence, which is set out in the presentation. I'll let colleagues read through that. Steve touched on the communication and engagement element of our priorities. That's a golden thread for us, really, in terms of what we do with this strategy and how we work with local people, how we work together as a partnership and with other partners that don't necessarily form part of our overall CSP, really focusing on how we get key messages out to local people. As Steve said, we have lost our way over the last few years, and it's something that we're starting to work on already, just in terms of how we communicate our perception levels. So when you measure the perception of how people feel about crime and disorder are really, really poor. So it's something that we're very keen to address, and that whole element of supporting victims and making people feel safe and able to report crime is really key for us. There's no way that we can tackle any of these issues on our own. So really ensuring we have an effective partnership approach, working collaboratively, making sure we're sharing information appropriately is another key element of our approach to this strategy. And making sure that we're aligning with other key strategies and the work of the number of boards that we have operating in Reading as well. So again, why we're here today is to ensure that we've got that cross collaboration as well. I've touched on it a couple of times. Victim support is really key for us. From a local perspective, we have some elements of that, but really drawing out how we can support our victims in a more sustainable manner moving forward, and making sure it's at the heart of our problem solving and response to crime and antisocial behaviour. And then finally, just adopting the One Reading Partnership approach in terms of continuing to the aim to be a trauma-informed town. So really building that into the work we do with our workforce who are involved in tackling crime, ASB and social behaviour, and then just in terms of our overall case management. So those are the kind of underpinning themes for our approach for this strategy. I'll now hand over to Steve, who will talk through how we're starting to develop the plan and our delivery mechanisms.
Thank you. I don't propose to dwell on this too much. Really, it's just to mention the next steps, really. So I'm very keen that we have delivery groups that deliver these as a set of priorities, and that we're really clear on actually what are the mechanisms, what are the outcomes we're looking for, so that when we do come to report back, you can see some of the bits and pieces we are achieving in this space. We're still in the process of working through what that looks like, as some of them exist and some of them don't. A good example of that is there's currently no real mechanism for how we talk as a partnership about violence against women and girls, and that's something that I'm very keen that we have. And again, around the kind of public engagement piece, I think we've just got to be really clear about what that plan looks like so that we can articulate it. And there's just an acknowledgement that actually this is a difficult time for public finances. We know we can't achieve everything. This is a big space. Perhaps what we want to deliver and the reality of what we can deliver across the board is two slightly different things. And there's got to be an element of realism here around actually what are the things we really want to achieve and hone in on, so that we can just protect some of our resources, I think, a little bit. And then I'm not going to labour the point about, I've talked enough about communication, but one of the things which is clear is when you go out to public consultation and you say to the public, what is the CSP, what does it do? There's a gap there, and we need to kind of bridge that gap.
Thank you, Steve. So that part of the presentation is in relation to our community safety and serious violence strategy. I'm happy to pause and take questions at that point, unless you're happy for me to move on to the domestic abuse part. So however you'd like to proceed.
Do you want to carry on, unless anybody's got a question now? We're happy to carry on. Yeah.
Okay, thank you. So running alongside our timeframes for delivering our community safety and serious violence strategy, we've mirrored that with our domestic abuse and safe accommodation strategy. So in terms of the delivery of the strategy, that was actually adopted by Housing, Neighbourhoods and Leisure Committee on at the beginning of this month as well. So we followed the same timetable. But in order to get to that position, what we had to do was ensure that we were complying with the Domestic Abuse Act, which came into statute in 2021, and placed statutory requirements on local authorities to assess the needs of domestic abuse support in local areas for all victims who reside in relevant safe accommodation, including those from outside of those local areas, and then to prepare and publish a strategy for the provision of such support to cover the area and having regards to the needs assessment. So again, as I've kind of touched upon with our community safety and serious violence strategy, we undertook a comprehensive needs assessment in terms of understanding the need for support and safe accommodation in Reading for victims of domestic abuse. That was carried out during the early part of 2022. And in the same way that we identified the priorities for our community safety strategy, we pulled together a number of priorities, working with our Domestic Abuse Partnership Board to put forward for public consultation. The local partnership boards were also a requirement that was set out in the legislation. Reading had a domestic abuse steering group, but what we did at the beginning part of 2022 was revamp our steering group to become a domestic abuse partnership board. We have a range of partners who sit on that board. It's led by the Assistant Director of Housing and Communities from the Council, and we have partners ranging from Thames Valley Police, Berkshire Women's Aid, a number of support services, as well as health and adult social care, and Brighter Futures for Children. So, as I say, we became the Domestic Abuse Partnership Board at the beginning of 2022 with new terms of reference, and the board is a subgroup of our community safety partnership. So we provide, I say we, the community safety partnership provides scrutiny over the board's activities and has oversight of the action plan. So the needs assessment was something that we've done solely focused on domestic abuse for the first time. Obviously, we had to do that in terms of the Act, but it was a really important piece of work for us as a partnership board, because actually we hadn't undertaken any real assessment of the needs of our victims of domestic abuse for some time. What we identified out of that needs assessment were the priorities, which I will just run through now. So remembering the overarching statutory requirement is around the provision of safe accommodation. We were also coming into a time when our current contracts for refuge provision and non-refuge support were coming to an end. So the most important priority for us in the first instance is to effectively commission refuge and other safe accommodation spaces for victims of domestic abuse. So I'll come on to that shortly, just in terms of where we're at with that. But in terms of the other priorities, there was one around, again, communication, so raising awareness about domestic abuse. Another important one for the board was how we engage with victims in diverse communities experiencing abuse, with a view to encouraging trust to remove barriers to access support services. So that was one thing we identified through our needs assessment as well. And then to develop and support a multi-agency approach to working with an array of groups, inclusive of perpetrators, victim survivors, irrespective of gender, sexuality, identity. So there's a piece of work that's been looked at in terms of perpetrator programmes, but an important area of work for the board was how we work with victim survivors from a range of groups, and it was something that we felt was a real gap. So there's some intensive work being undertaken to address that, working with a range of partners, including Support You, and how we integrate with ACRE more effectively in terms of the work we do around domestic abuse. And then finally, the last priority is to continue to safeguard and advocate for all children who have witnessed and experienced domestic abuse. So cross-referencing the work that's undertaken by Brighter Futures for Children, but also the programmes that are delivered by our voluntary and community sector partners as well. So PACT, who operate out of Alana House, run projects for young people who have witnessed or been victims of domestic abuse, so making sure that we can sustain those types of programmes as well. So just in terms of where we're at now, the strategy has gone live. The Domestic Abuse Partnership Board are in the process of finalising an action plan to accompany the strategy, and that will be updated through the Community Safety Partnership in February. Just in terms of a light touch, this is where we are. Going back to the contracts with that we have with our current provider. So as I mentioned, they had come to an end. We're in an interim contract arrangement at the moment to ensure that we continue to have refuge placements for victim survivors, but utilising the needs assessment in terms of identifying what we would like to see and what the need is in terms of safe accommodation in Reading moving forward. So we're in the process of actually developing the specification for that at the moment. What I would say is that accompanying the Domestic Abuse Act is new burdens funding that has come through from the central government in terms of supporting local areas to deliver safe accommodation provision. So Reading has been fortunate enough to receive significant funding, around £400,000 approximately per year, and we've had our settlement for the forthcoming financial year and the financial year after that as well. So it has put us in a strong position in terms of the commissioning element, but what we need to think about is the long term, because that money won't continue in future years. And so that was really just to give you some oversight in terms of our domestic abuse work as well. I'm conscious that within the health and wellbeing strategy, there's reference to domestic abuse, so I thought it was important to highlight that. But Steve and I were just keen, really, following the presentation, is to just have some thoughts about how our strategies link cross-reference over to the health and wellbeing strategy and any other strategies that are being worked upon. what we don't want is any duplication, but also what we don't want is to miss anything as well. So making sure that from our perspective, in terms of the work we're doing around crime and disorder and domestic abuse, that we're clear in terms of the work that we're doing is complementing any work that's coming out of this strategy, as well as making sure that we're clear on who's leading. So thank you, everyone.
Thank you very much for that update and report. Any points, any questions? Oh, apologies. Sorry. Alice, you wanted to speak?
Yeah, thank you, Chair. Just to share with you, in the sense of when it comes to ethnically diverse community, I think it's the language that we use. Even in health, is the same thing. I think we need to look at the language of how they understand domestic abuse or crime and things like that, because they don't, if you're someone from abroad, this kind of stuff are not highlighted in their community. So I do think that there's a lot of work needs to be done about the language that we use. And that's, we in my organization as Health Watch, we've had to look at the language. It's same like, when you look at learning disabilities, it's about the easy read. Do people really understand what you're saying?
Thank you. And it's something that we're really keen to address at the earliest point within the action plan work that we're delivering as well. So particularly through that comms and engagement piece, through the delivery group that we're looking at establishing, it's really important for us that that's one of the first pieces of work that we start tackling. So thank you.
Thank you.
Alison? Thank you, Alice. Alison, did you have a question?
Yeah, Alison Foster, Programme Director for the Hospital Redevelopment Programme, Building Berkshire Together. It strikes me, just listening to some of the previous presentations, and I'm going to be talking about it as well in terms of comms and engagement, how maybe there's opportunities to join up across public sector a bit more. We're out to a survey at the moment. ICB is, Health Watch are running a survey. We've all got engagement events. That there may be even at a small level of join up where, if nothing else around, so you mentioned about people just not being aware of what a community safety partnership is. That's an easy ask to have things that at events, that certainly we could do. And I didn't know if anyone had considered, a partner comms board that comms group that doesn't necessarily have to meet very regularly. In the Reading Climate Change Partnership Board, all our partners, we have a regular comms meeting where we share each other's comms and just say, here's what we're doing for the next 3 months. And they say, oh, can we come along to that? Or could you take this with you? And I just wonder if there's an opportunity with partners on the Health and Wellbeing Board to do something similar if it's not in place already.
So that's one of the things that we're looking at establishing through our community safety partnership delivery mechanism. So we've had very, very early conversation in terms of how we can bring partners into a conversation. So whether it's a steering group or kind of whatever we frame it as, but we're very keen on pulling together all those that are involved in surveys, engagement and that kind of thing, so that we're not duplicating again. And there's always the risk of survey overload. You've just kind of described it there. We know the Police and Crime Commissioner recently conducted a survey as well that kind of might conflict with the community safety survey that we want to launch. So what we can do from today is I can send out my contact details to help formulate that group a bit more kind of cohesively, I think, and make sure that we've got the right representation. But that's the kind of element that I'm happy to lead on in terms of that comms piece.
Thanks, happy to help.
Thank you for that. Thank you. Martin White online.
Thank you, Chair. Yes, Martin White, consultant in public health from Reading Borough Council. I'd just like to say that I'm ready when you are to have a conversation about how we can explore the links with the health and wellbeing strategy. I note that it appears in priority 2, the word violence and domestic, I think it's called domestic violence there rather than domestic abuse, but it appears in priority 2 in the in the strategy. It also affects the mental health of children and adults, so it would appear in priorities 4 and 5, but I note that is the implementation plan for priority 2 is lost at the moment. So I'd welcome that conversation to discuss how we can develop the implementation plan, overcome the silos that may exist between our 2 areas of work, and implement a public health approach to violence prevention.
Thank you, Martin. Councillor Brock?
Yeah, thank you, Chair. So firstly, thanks to Joe and Steve for the work they do with the Community Safety Partnership. And I think actually have done a really good job together at reinvigorating it and making it much more sort of meaningful. If only the budget hadn't been cut by 50%. But it has been nice to be part of it over the last year. And I agree with Ali as well, actually, that there's more that we could do as public sector organisations in terms of joint comms, and it's something I often bang on to partners about, but often those conversations start to break down when I sort of point out that I would quite like the council to, with its much more successful comms team, to lead those comms, but there we go. But a really important point I was just reflecting on is sort of, you know, Joe came and asked a really pivotal question about, you know, how does this strategy engage with, interact with, interface with the health and wellbeing strategy, and got an answer from Martin, who's also a council officer, joining us from a U-boat in the mid-Atlantic, I think, or something like that. But it sort of expresses something which I think is needed here in the Health and Wellbeing Board, which is, although we meet as a board and the partners are here and around the table and we have a good conversation, I don't think it meaningfully fires as a partnership in the way that it should. And I think we should go on that same journey of reinvigoration that the CSP is going down, so as to make it work much better moving forward, because otherwise we end up sort of sat here listening to presentations, and it always provokes some interesting comments. I'm not saying it's a useless endeavour, but it could be more useful, and it should be most useful outside of this room in terms of having a partnership that endures and works and interacts with the CSP and all of those other organisations going on as well. Rambly answer to a question nobody asked, Chair, but nonetheless I provided it.
Well, thank you very much. Any other comments or questions that I've missed? Don't want to miss anybody. Okay, thank you both very much. I really welcome both the reports. On the first report, obviously welcome report, and the community engagement obviously is incredibly important, and we've kind of touched on it really, talking about the communication, but I was asked what can the Health and Wellbeing Board to support ongoing work. And in relation to the domestic abuse, again, really welcome the strategy, look forward to seeing the action plan, and just to ensure there is a shared understanding of the issues, how can the results of the needs assessments be circulated, and again, what can the Health and Wellbeing Board do to support the work. But, you know, obviously others, Jason and others have touched on that, the communication, I think, is a really important issue. So thank you both very much. Thank you. And so we're moving on then to agenda item 8, which is an update on the Pan-Berkshire Suicide Prevention Agenda, which is to be presented by Tracy Dakovich. Oh, sorry. And Dan. Apologies, Dan. Dan Devitt. Oh, apologies, Dan.
Thanks, Councillor McEwen. My introduction will be brief. Dan has, he's definitely the brains of this work, so I will be handing over to him shortly. But thank you for letting us bring this agenda item back. We first brought it to Health and Wellbeing Board last summer about looking to do a refresh of the Pan-Berkshire suicide prevention strategy. A huge amount of work has gone on there, and a huge amount both in terms of engagement, research and evidence review has taken place. So it's important that we came back to share with board not only the work that's been done, but also the next steps, which I will hand over to Dan, and he'll be able to give you the detail on all of that. Thanks so much. Over to you, Dan.
Thank you, Tracy. Very much appreciated. I'm just going to share with you a brief slide deck. As I start, I want to preface today's presentation with a couple of notes. First of all, obviously, we're talking about suicide today. That is an inherently distressing subject area. So please do practice self-care today. Reach out to those people that you feel that you can talk to if this is something that troubles or triggers or distresses you. If you've got any support needs, please don't hesitate to drop me a line or other colleagues that you might feel safer with. And there are contact numbers supplied within this presentation, which I do urge colleagues to reach out to in this very, very challenging environment. Second note, as a preliminary, is that every item on the Health and Wellbeing Board that we've had thus far, and the items that you're going to go on to consider, has resonances and connections with the suicide prevention agenda. And I want to take this opportunity to really place front and centre the works that have already been delivered, the works that are underway from colleagues, both at the region, the Southeast regional level, the county-wide works, and of course, most importantly for today's meeting, colleagues in the Reading system in terms of both the community safety facing and public health facing officers. You are all making significant and serious contributions to suicide prevention. Thank you. So today, I'm going to try and give you a very, very brief update in support of the papers that have been presented on the national, county and local data and RTSS insights, the real-time suspected suicide insights that have been shared with us at county level. To note that since the issue and the drafting of the initial reports to the Health and Wellbeing Board, we have had data updates and we've done some further research, which we're presenting with you today. This slide deck will be shared with colleagues after the session. We're going to give you a quick overview of the Pan Berkshire strategy, consultation steps, and some of the challenges and some of the issues inherent within that, and then outline what our proposed next steps are and present and ask for your acceptance and engagement with the ongoing development of the strategy. The national picture is inherently complex. There are multiple data sets, multiple ways of looking at the suicide prevention agenda, many ways of looking at the different components of the system that support the analysis and learning arising from deaths from completed suicides. Nationally, from 2000 to 2021, we've had 103,000 plus completed suicides. That's a startling figure. In Berkshire alone, in that same period, over 1,295 recorded deaths, and in Reading Borough Council itself, 134 people have completed suicide since the year 2000. A startling and challenging figure. Single year national data shows us the related data set for self-harm admissions reaching 102 and now clearly much, much broader and over that 103,000, 110,000 threshold for self-harm admissions recorded in the English system. 2001, Berkshire recorded, there were a total of 5,583 completed suicides registered in the English and Welsh systems, which gives us a basic rate of 10.7 deaths per 100,000 of population. Our context in Reading is troubling. We have a profile that shows 49 completed suicides from an ONS perspective, from that robust data set and national intelligence point of view. 35 men, 14 females have taken their lives from Reading. This shows a significant challenge to us in terms of rates. And when you dig into the details, some of the complexities flowing from the suicide agenda are immediately apparent. The disparity in rates between men and women and the different age groups represented within those troubling statistics. The real-time suspected suicide data set flows from our colleagues in Thames Valley Police, without whom much of this work would be impossible. So again, if I may, my thanks to colleagues, and in particular Nicola Wilding Singh from TVP, who has made this such an essential and supportive input into the Pan-Berkshire suicide prevention works. We are presented with, again, a different data set that's looking at what is termed as probable or likely suicides. Very different data set from the ONS data and considerably larger in scale. Reading, in the year to date for 2022, reporting 15 active deaths within the Reading boundaries. Important to note here that RTSS data captures deaths in a location, not necessarily by their home residency or by their home residency or origin. So as a consequence of that, we have a very keen interest and an active work stream in exploring with neighbouring regions, neighbouring RTSS systems, areas where we know that Berkshire residents or Reading residents have moved to a different area and taken their lives. The refresh strategy, it builds on the work that has already been developed over time in the Berkshire system, and in particular two starting points, the 2017 initial strategy and the October 21 refreshed version. This was agreed in some areas across the Berkshire system in January 22 and was put into sort of semi-operational status from that point. Between January and June 22, a number of significant, may I say, seismic national challenges and developments came to pass. Chief amongst them, the NICE guidance NG 225 on self-harm, really radically changing the approach to self-harm and the awareness and indeed the need for services to move from a mechanistic risk assessment approach into a more personalized psychosocial assessment of individual need, with significant changes required for suicide prevention work to support and encourage that community awareness and professional awareness of the changes within the self-harm guidance. We have recently understood that there is going to be a refresh of the National Suicide Prevention Strategy, which is anticipated to be with us by about March later this year, and a significant number of other additional resources, including a revision of the OHID suicide cluster prevention guidance and a number of other key targeted engagement resources and materials from both a regional and a national basis. Alongside this, we naturally have developments within local authorities, challenges of delivery that have already been discussed in the context of adult social care. And we also have significant system developments, including the formation and development from 2022 of the NHS ICB systems. Berkshire itself straddled with the Bob and the Frimley ICS systems, and a need to make sure that both are aligned and coterminous with local county-wide suicide prevention works. One of the chief issues set out in the paper and one of the chief purposes behind the strategy is the need to balance the very, very wide range of priorities and the specific need to have a universal facing strategy that is also capable of representing, identifying and delivering for the needs of very, very vulnerable groups who may have specific cultural requirements or occupational or age range related needs. There is a real trick here to balance the national imperatives of suicide prevention alongside those county-wide requirements and local action. And really our strategy is aiming to support a mechanism and a new partnership approach that balances both those scales of needs between universal and individual, and also those national to local actions to make sure that this is a sustainable and modifiable plan that will grow as our understanding of the suicide prevention agenda and our links with other systems and linked agendas develops over time. The strategy itself was launched from a professional facing consultation point of view in December last year. There are links across this PowerPoint and within the appendices for the committee report that set out the core aspects of the strategy itself, which pushes us towards a zero suicide ambition. We are explicitly rejecting the idea that in some way, shape or form, suicides of any nature are in some way acceptable. We may not be able to prevent all of them, but we should be trying. We should be ambitious to try and prevent all of those suicides. Please do feel free to share this document with colleagues, with your local systems. Please help us shape the next steps for the strategy. Recommendations and next steps as set out in the appendices and the recommendations for the paper. There are a number of documents and opportunities presented. I commend them to you for your consideration, and I look forward to receiving your feedback, and I hope your endorsement of the engagement approach that we've set out today, and in time that you will accept the strategies as it is matured, feed into that strategy, and then agree it in time. We are hoping that the consultation itself will run from March to April. That's to be confirmed, bearing in mind that there are local elections and the potential impact of PERDA may have an impact on the consultation itself. And there is also going to be a consultation opportunity for the wider public. Now, it's important to note the current consultation is very much focused on the professional governance, from the clinical, from the public health, from that wider statutory and voluntary and community sector systems approach. We are going to be doing a wider public consultation opportunity looking at a more broad and more generalized suicide prevention awareness agenda. You take very, very different approach between the different conversations, and obviously we must make sure, in line with the needs of our communities, that that consultation is informed with culturally competent practice and a very inclusive approach, so that we can ensure that a wide range of communities feel confident and comfortable in telling us about what their understanding is and how they would like to see themselves involved in the prevention of future suicides. Pending your support, we would then go into the phase of next steps in development, and I look forward to hopefully working with you again on this agenda in the future. Commend the report to the committee. Thank you.
Thank you very much for that presentation report, Dan. Do we have any questions? Councillor Hoskins?
Yeah, thank you. And thanks for the presentation. Really, I really do welcome this, and I think this is some really good work, and it covers a lot of the areas that that I would have raised if they weren't in there. So, you know, around sort of the impacts and sort of the trail of COVID, the pandemic, the cost of living crisis, and the stuff that would be in there. And I was going to ask, but you mentioned it at the end, around, because I think it's really important, that wider public consultation, because I think actually the perspectives we get from the wider public will inevitably be very different to the sort of the professionals. So that's really important. So I was really pleased to hear that. So I suppose my question, yeah, well, I mean, I should also say, I mean, it's really pleasing to see, I think, the progress on these kind of strategies. You know, we do see real, you know, better strategies and, you know, and more effective, you know, a more effective, I mean, I haven't got to the action plans, but, you know, it feels it's, you know, it's really working in the right direction. You know, I'm thinking back, you know, 10 years or 15 years or so when we started doing these things. So my question is around, slightly twofold. I've got real concern, I suppose, around, and this is a little bit about, funny enough, come back to professionals, really stretched public services. I think if we look around Reading, we see public services really sort of spiraling into crisis, whether that be the police struggling to, you know, to keep up with demand, probation, schools, the NHS, and also, you know, council services as well. So I suppose there's something there about, is there something that we need to think as employers much more than we have done in the past in terms of care of our staff? But the other thing is around, and I'm lead for children, so it's kind of been thinking about this for a bit, but also parents also been thinking about it for a bit. And that's our school system, which I've got a lot of issues around how the English education system works, which I won't go into. But one of the things it does seem to me is it doesn't seem to take a great deal of attention to the mental health and well-being of either pupils or staff, and sometimes even parents, and how it's organised. It seems very much focused on, very hard outcomes rather than how people sort of, emotional states within that. And so that stretches all the way from the high pressure of achieving outcomes, Ofsted inspections particularly for teachers and leaders, just things like how the lunch hour seems to have been abolished within schools. Kids don't get a chance to relax and unwind during the school day, and it's just like go, go, go. So I just wonder if your views around that, and if that's something that we really need to, I think we do, really need to sort of perhaps bring back a human approach to education in schools. Thank you.
Thank you, Councillor. I think actually in the last part of your answer, or of your question, you more or less answered in a very, very brief sort of section, used the phrase a human approach. And ultimately, that is what we really are trying to build in across a wide range of professional inputs, and from a very, very broad and very early stage. It's important to notice, as we've discussed earlier with regards to, say, mental capacity discussions, our awareness of what the suicide prevention agenda looks like and what is effective in that space has changed significantly, even within the last 3 years, let alone the last 15 or 20. Culturally, we as a country are on a very regrettably slow but a definite journey towards having a more sympathetic and more aware space to discuss and awareness of issues around mental health and well-being. Now, without being drawn into the sort of the specifics of the school's policy environment, I had the privilege of working with DFE colleagues in the mental health support team, interface with the NHS in other regions, where front and centre, at the absolute heart from their perspective of what they wanted to see evolved in schools facing policy was the inclusion and the holding of the pupil, the support for the family, and from extension of that, the community, along with the staff, across a wide range of mental health and well-being issues, including responses to, say, the COVID crisis, responses to academic stress, responses to suicide prevention in its wider terms. We are not at the end of that journey, and that debate and that discourse is something that we want colleagues such as yourselves to be feeding into that strategy and keeping it refreshed, making sure that those links, those connections across adults and children's services and that broader community space can drive that inclusion and that honesty and that support for the suicide prevention discussions that are necessary if we're going to stop people dying. Thank you.
Thank you.
Thank you, Councillor Hoskins and Dan. And I think Brian Grady's got a question. Hello there, Brian.
Good afternoon, board members. I found it a really powerful presentation. I think I'll just add it on to Councillor Hoskins' comments that the importance of working across children's and adults really welcome in the strategy. Our work in children's services and with Reading schools and building on Councillor Hoskins' point, the trauma-informed approach that we have across our schools, I think is a really good example of how perhaps we need to amplify that in terms of our wider mental health and wellbeing work, but also in terms of the support for this work as well. So I think it's that national challenge that Councillor Hoskin identifies. There are real opportunities here, I think, locally building on our trauma-informed approaches, our local mental health and wellbeing approaches, and really welcome the engagement that schools and children and young people services have had in the development of this work. So it's more of a note of thanks, really, Chair.
Thank you, Brian. Do we have any other comments? Nobody missed? Okay. Yeah, thank you, Dan. I really welcome the report and the updated statistics. Obviously, they are worrying. I really appreciate the extended consultation, as it's obviously such a very important issue. When might we see the final strategy and action plan?
We are hoping that we'll have a version of that report as near as we can finalise it by March. It is subject to some of the things that are out of our control in terms of the wide range of 6 local authorities and other partners, and a very vibrant VCS environment that we're trying to engage with, so that we can actually refine the professional facing strategy. Alongside that, obviously, we do, I understand, have the May elections to contemplate, and the specific local decisions on whether or not PERDA it will be imposed, and whether or not this would be an area of policy or development that would be halted or paused because of PERDA is something that's been considered in different authorities across the Berkshire region. We are again hoping that we'd be able to share with you by March what that finalised strategy looks like, but it does depend on the political environment and, of course, the richness of the engagement that we get from this and other engagement opportunities that we're sharing.
Thank you, Dan. And we have Deb Hunter online. Hi, Deb.
Thank you. Sorry for coming in late. Thanks very much, Dan and Tracy. Hugely interesting, very moving. At the Suicide Summit in December, which again was an incredibly powerful meeting, there was some discussion about using specialist organisations such as Papyrus, for instance, in thinking about raising suicide awareness, particularly in secondary schools. And myself and Tricia Pease at the time said we would welcome being part of that thinking, and the need obviously for caution, hence why the involvement of experts. And so what I was wondering was whether or not there's going to be any specific workshops where we have chance as a small group of professionals to talk through the best way of beginning to think about that, because we really need a very planned, coordinated partnership approach, I think, to rolling out suicide awareness, particularly with adolescents. And I wondered whether or not that was going to happen before the strategy was signed off, or if it has to wait until afterwards.
It is one of those things that's probably going to straddle from a development point of view. It will start before the conclusion of the strategy because it's a clear area of need. It will have to begin with the sort of the finalization of what our community discussions are going to look like, but probably the heavy lifting will follow from the creation of the strategy. The rationale behind that is that the strategy partnership as it stands now is effectively one body with a single subgroup that meets to consider very specific pieces of data intelligence and thematic issues. It's not actually well placed to do that broader systems communication and engagement with, say, specialist partners in the education setting, or perhaps specialist partners in adult social care, looking at residential care, the loneliness and the isolation sections, or particular population groups who are vulnerable. So a bit of a mixed answer there, but effectively we are going to start some of those works, but we are hoping once the strategy is hopefully approved to do the heavy lifting on the schools facing work from that point.
Thank you.
Thank you.
Thank you both. I have a Tracy Dakiewicz.
Thank you, Chair. Sorry, I know you were trying to bring this to a close, but Deborah's comments have triggered a thought in my mind in terms of recognising the importance in this space around suicide is notoriously underreported. When deaths by suicide go to inquest, they can often be recorded as a narrative verdict or deaths by misadventure and a range of things rather than suicide. For suicide to be recorded on death certificate is quite challenging, and by virtue of that, those start figures that Dan put out we would estimate probably represent possibly only 30 to 50% of suicide cases. The suicide profile is changing, particularly around children. Councillor Hoskin talked about cost of living and lockdown and COVID and how that is impacted on the adult profile, but actually the profile is shifting quite dramatically with children and young people. And some of that is around, we have seen deaths as young as children, there've been well documented deaths on the news of 12-year-olds and even going into primary age in terms of how difficult things can be for some of our young people. And some of that is down to social media and children that are having a difficult time at school that follows them home and into their bedroom through their devices that are very often glued to their hands, and how we get to those children and give them a place to express the pain that they're going through in a place where it's often hard to do so. We're doing a lot of work in terms of raising the profile in terms of the 15 minutes of despair. Whereas if we can distract people for just 15 minutes in their moments of despair, we can alter the thought process and probably save a life. So it is about interventions and those small things that all of us can do to have greater awareness of our colleagues, which is hard when we're working from home, but just to be aware of people's low points and being aware of people's changing mood. People are very good at disguising when they're unhappy. And this is why suicide often comes as such a massive shock, because, well, he was always so jolly and he was always so present. You hear this all the time, but we need to be aware of that with our young people as well. So I think the point that Deborah made was very well made in terms of how we take those conversations forward. Thanks very much.
Thank you, Tracy. And again, thank you to Dan for the presentation and for the report. I'd just like to add, I attended the event in December, and as Dev said, it was very moving, very interesting, but a really moving and informative event. So thank you very much. Okay, thank you. No other questions? Okay, thank you very much then. So we're moving on then to agenda item 9, which is the Berkshire West Safeguarding Children Partnership. It's the annual report to be presented by Esther Blake.
Thank you, Chair. So I'm Esther Blake. I'm the Partnership Manager for the Berkshire West Safeguarding Children Partnership. I'm here representing the executive group, of which Brian Grady is a member, so I'm sure he'll be able to come in with some comments when I've just finished the presentation. I'm also representing our new independent scrutineer and chair. So as Professor Keith Brown was here earlier for the Safeguarding Adults Board, I'm hoping that our independent scrutineer will be here in subsequent years to be able to present this report to you and give you that more independent view. This report covers our new Berkshire West Safeguarding Children arrangements. Working Together 2018 obviously asked us to review the way we looked at our safeguarding partnership arrangements, where we used to have individual local safeguarding children boards based on local authority areas. We felt that mirroring the approach of the Safeguarding Adults Board and pulling together a Berkshire West partnership was going to be a sensible way forward and allow us to share information and good practice and really be able to work in a more productive way. And we are moving in that direction. It's still embedding, I would say, but we are moving in that direction. We have conversations between our new independent chair and with the independent chair of the Adults Board, and much of the work that we are looking to do, we are looking to work alongside other partnerships, so particularly around the adolescent risk and serious youth violence. We're doing work alongside with the CSP and the new strategy that's been described here today. So there's some really positive steps to try and align a lot of that work. In terms of this reporting period, the report just lays out the work that we have undertaken as a partnership. So that covers all 3 areas, but what I've pulled out in the covering report is just some areas that are slightly more specific to Reading. Some of the key elements, probably just to bring to colleagues' attention is really the work that we've done around the threshold guidance has been really positive. We've managed to align our guidance documentation across Reading, West Berkshire and Wokingham, so it's all virtually the same. So for those partners that work across the patch, if they're looking to understand what threshold they should be looking at a case, it's going to be the same threshold level in each of the 3 areas. Each area has its own document to allow for the individual pathways that those referrers would be following, but I think that's really supporting our practitioners, frontline practitioners, to have a better understanding of how to interpret those thresholds out there. Some of the key work that we undertook in this year was in response to, at the start of the pandemic, we had a really high number of significant safeguarding incidents for children and young people. And the knock-on effect of that has been some of those initial rapid reviews converting into child safeguarding practice reviews. And that takes up a lot of time and energy for partners. And it's really positive that partners in Reading and across the patch have been really supportive in those arrangements. For Reading in particular, those safeguarding practice reviews have focused on serious youth violence and adolescent risk predominantly, but there have been additional incidents that have really focused on cases of neglect and non-accidental injury for children. So moving forward, we are looking that those are going to be the 2 key main operational areas for our partnership in the remainder of this year and moving into next year. What has been really positive is the introduction through working together of a rapid response, a rapid review approach to any significant incidents when they are brought to attention and when we have to notify Ofsted and DFE. You heard Keith earlier talking that the safeguarding adults approach is looking to mirror that, because it really gets that learning out there a lot quicker. And there was some really helpful evidence that came back from a review that we undertook of all of our rapid reviews, particularly in Reading. There'd been a concern about fathers not being as involved in the assessment process, and following a rapid review that we undertook here in Reading, there was then an audit which really showed that social workers were really trying to engage fathers within those initial assessments and conversations. Some of the other work in line with the adolescent risk work is that every year we have a really detailed conversation about the Reading Festival. I mean, it's such a key pointer and moment for the town, but the safeguarding of our adolescents, and there is a very high volume of adolescents that attend that festival, so looking to keep them safe and making sure we've got partners really working together around that is really important. And our education groups that sit within our safeguarding structure, partnership structure, are always really keen to be very much involved and share that information and help with the learning and development of how we support that festival to be as safe as it can be. I think that's probably one of the key areas. As I said, we've also, this past year, recruited into our independent scrutineer post, who also chairs the number of our meetings, and he's really helping us to work together as a Berkshire West group to look to how we can improve our quality assurance and our data set work, so that we're really working on the best and informed evidence when those groups are having those really important discussions. But it's been really helpful sitting here today, because so many of the discussions obviously here feed into the work of the Safeguarding Children's Partnership. Thank you very much, Chair. Open for questions, unless Brian would like to say something as an executive member.
Thank you, Esther. Brian, did you want to speak?
I mean, the reason, Chair, that oh, I can't help the echo. Apologies. The reason I haven't presented this is it's a bit like the interim executive director for children marking their own homework. So the importance of independent scrutiny is a key feature and factor of this report, and therefore I would both commend and support it to board. I would just reiterate something that has just been touched on, really, which is that the learning from rapid reviews feels like a positive step forward in us understanding how we can improve, and therefore that sort of collective approach to learning and development, I think, is a strong area of improvement. And there have been other areas of progress that are set out in the report. I'm happy to support either on a single agency or on behalf of other colleagues any other responses that the board members would like to receive.
Thank you, Brian. Councillor Hoskins.
Yeah, no, thank you. I'd like to welcome it. I think it is a good report, and particularly the well, Brian's already said it. The sort of the question of scrutiny, challenge, and reflection through it. And actually, the scrutiny and challenge elements are really helpful because and a sense of looking to learn. I mean, I think this is the right approach. We talk about how Woking and West Berkshire are, quite different to us in lots of ways, but actually, Reading merges across those borders, and issues around safeguarding, what happens with families, and all the rest of it. We know, it swirls around Reading and the suburbs, and I think that Berkshire West approach can have real dividends. But also, I was really pleased to hear, and it was earlier on, that because that's absolutely important, that the children's safeguarding, the adult safeguarding, and the crime partnership, crime and safety partnership do work together in order really to get the best possible outcome. So yeah, I think there's an honest report here talking about the real challenges and some of the things to work on, but I think it's a good one, so I welcome it.
Do we have any other questions on this? No. Thank you very much for the report. Welcome the report and all the information included. It's very helpful. Thank you. Okay, so we're moving on to agenda item 10, which is refresh of the Berkshire West Local Transformation Plan 2023 and 2022-23 and 23-24. And I understand it's Deb Hunter and Leisure Johannesson presenting online. I'm not sure who's presenting. Lila, sorry, apologies.
That's all right. So I will make a start. Sorry, it's a bit echoey. And then Debs will finish off with the priorities. I think what we want to show is how we work together to develop this plan. Shall I share the slides on screen?
You can, or I can, whichever you prefer.
So I think I've got them handy just here. Let me put them on the slide. So what I'm hoping that you'll see is how this follows on hopefully quite neatly from some of the presentations that you've already seen, particularly the Dan presentation and some of the safeguarding discussions that we've had. So this plan is really around how we refreshed the local transformation plan for CAMS for 22-23, which is ongoing work around how we're developing children and young people's mental health services across Berkshire West. So we thought it was helpful just to do a refresh background information. So the local transformation plan is a national requirement through NHS England. It started when the programme for the 5-year forward view, which is now the 10-year long-term plan, came into being in 1918. So it sets out how local services are going to invest resources to improve the services for children and young people's mental health across the entire system. These plans are considered to be live documents, which I think is really helpful because you will know yourselves and the work that's happening within Bob is that it's quite a evolving situation we have at the moment. Local areas will be asked to refresh and republish every single year. So what we're working towards is to have a publication that will be on the Bob website in due course. This plan would describe how we're going to deliver the long-term plan, the NHS long-term plan, for 23 until the end of the programme 2024. Every time that we have to have a refresh plan, NHS England will provide us with key lines of inquiries that they want us to include in the plan. Normally we have a whole year to do these plans. This time we got told in July that had to be published or at least developed by the end of October, including all these elements in it. So it's a fairly sizable piece of work. Ordinarily, we would have done much wider consultation, but I think you will see that given the timescales that we have, is building on existing work around partnership and engagement, that we managed to capture some interesting feedback from individuals that helped shape the priorities.
Taylor, I'm in terms of your presentation, you're on the first slide. Did you mean to be on a different one?
Oh yeah, sorry. I'm clicking through the slides, but they're not.
I think you're sharing the wrong window, so you need to share the actual slideshow.
I thought it was on the slideshow. Hang on, let me just go to the beginning then.
The one that you're actually sharing is not the one that you think you're sharing, I think.
I'll share. Can you see that one? Sorry.
That's better. Yeah, now you've got the actual slides. Thanks.
Let me just go back one. I think you've got this in your pack anyway. So these are some of the key lines inquiries that we have to include in the plan itself. So it's quite comprehensive. The next one, really just to refresh our memories around what's in the NHS England long-term plan in terms of priorities for children mental health. So it talks about 0 to 25 services and increasing access within that. And actually locally, we have met that target and we are exceeding some of the targets for improving access. Now, we all know that there's more demand coming through at the moment. So although that looks quite good, there are still issues with getting access to services. Children and young people's eating disorders continues to be a key development within the programme, and we'll come on to that. Mental health support teams is another one that you'd probably be quite familiar with. And then children and young people's crisis services, about having 24/7 mental health crisis care provision for children's mental health services. And the latest thing is about developing intensive home treatment functions within those crisis services. And inpatient services is about working with the PCN. Sorry, my slides have just disappeared. With the our provider collaboratives, and we've got some quite exciting work that's happening within that, where we've included VCS services to develop some social prescribing to enable some of the young people to be discharged quicker. And then digitally, it continues to be an important part of the work that we do, so we can start capturing outcomes, but also really understand how many young people we're working with, and to what degree the investment that we're making is making a difference. And then the next one is really our ambitions in Berkshire West, and what does that actually mean in practice. So what we want to do is understand the different needs of the populations across Berkshire West and how we can develop services to meet them appropriately. So we've done some work around population health analysis, where we've gone out and worked with local communities, and that will start informing some targeted approaches as this programme develops over time. Identify gaps in care and make a shift towards prevention and early intervention. So I think, you know, you've heard quite a lot this afternoon about complexity and acuity increasing in children and young people. And so whilst we've been grappling with this for the past 2 years during the pandemic, there is now a real ambition to start doing some thinking about how do we start shifting back into that prevention, early intervention mode of thinking, which obviously was the intention all along with the blueprint for children and young people's mental health services. We want to identify unwarranted variation, and we're doing quite a lot of work across the BOB system to do that. Moving towards a system-wide accountability and shared outcomes, and I think you'll find that when Debbie starts talking, then that's sort of, it's all, these are all our children, these are all our common priorities around how we work together to provide emotional well-being and mental health services. The priorities, and again, Debbie will come into more detail around that. We divide into strategic, operational and co-production. So strategically, we're talking about partnerships and integration with a clear joint up approach across Berkshire West. Talk about how we're going to work together around developing and supporting complex young people. Suicide prevention is another key strategic priority. Quite keen to sort of followed on from Dan's presentation that actually we're all sort of feeling across the system, whether you sit in the NHS or local authority or the VCSE, that this is a real key thing for the Children and Young People's Programme that we need to be do more work on. Then operationally, obviously reducing waiting times continue to be one of our top priorities. Meeting the national targets around children and young people's eating disorders, and then again improving access around inequalities. And we are still seeing, as part of the mapping that we've done, there are certain groups that have more difficulty accessing mental health support. And then transitioning, and I think that was mentioned early on in the meeting as well, we are doing quite a lot of development work around the 16 to 25 and how that straddles into the adult mental health programme and some of the VCSE developments that are happening in that area. Again, mental health support teams is really a flagship priority within the programme, and then data and digital. And then finally, co-production is one element that I'm particularly keen on, that we start working much more closely, not just with our partners, but also with parents and young people, and how we're developing things and developing services. And I just want quickly to share with what some of the themes that have come out through our engagement with our partners. So there's quite a lot about importance around having common language, not using jargon, but actually using language. And I think that came out early on from Healthwatch around it is important how the words that we use in order to make our services accessible. Need for stronger collaboration to work through complexity, and thinking collaboratively on how we can support young people and access the most appropriate help and information. And I could go on, but I'll leave you to read the rest of it. And then very briefly, some current barriers and challenges are still about how we do some information sharing, and that's what we'll be working towards around developing a sort of single point of access, or at least access points, where we can have spaces that we make sure that young people get to the right service the first time round. Timely early intervention is another key thing. I think there's still a feeling amongst partners, and I'm hearing in this presentation as well, around that sometimes we intervene a little bit too late at the moment, and some of that obviously is also linked to increased demand and capacity within services. I think the other big thing that's come through is around staff wellbeing within our partnerships, that we also need to be looking out for our staff in order to provide good, safe services. And then again, need for a clear understanding about who fits within the different bits in the FRI model. So the FRI model is really a new way of thinking about developing children and young people's mental health services, that it's not a linear process, but actually you might need different levels of support at different points within your journey. So these are some sort of key elements that have come through. And then I think I'm going to hand over to Debs to just talk through the priorities and what the work we are anticipating that we'll be doing in the next couple of years.
Thanks, Lila. Be great if you're able to click through the slides for me as I go.
I'll do that.
So as Lila said, following the context of why we're renewing this annual plan, it's really a lot of the approach is really about improving and continuing to improve our partnership and integration, because it's a systems approach. As somebody mentioned earlier, you know, we no longer work in silos. If we're going to really improve children and young people's mental health, we need to do so on a system-wide approach. And so in terms of partnership and integration, you can see there some of the details that we'll be focusing on over the next year, and already have started on a lot of these. There's a review of the CAM spec, just as Layla said about the Thrive model, with a focus on early intervention and prevention. And in Reading, we've got a really good early intervention and prevention model, but we need to keep going and improving that and extending that, and working really closely with CAMS with our more complex children and young people, so that we meet the needs that are still out there and still rising. Expanding partnerships with the voluntary sector, and again, underneath it says using that common language, particularly important when we're working with our partners in the voluntary and community sector, because we want mental health and emotional wellbeing to not just be a medicalised model. It's got to be something that we all can talk about and all know where to seek help when we need it. And our voluntary and community sector are hugely important in that, because we need it to be a sustainable model moving forwards. It's got to be a community-based approach as much as possible. We are continuing to embed the trauma-informed approaches that Reading has been leading the way on, I think, for the last couple of years at least. We have commissioned some work at looking if it's possible to have a coordinated front door or Thrive hub, and we're just beginning to get some feedback about the initial stages of that piece of work. And of course, we need to make sure that we don't just work with children and young people from 5 to 18 or 25 in some of our services case, but that we link and integrate really carefully with preschoolers 0 to 5 and 18 plus. Next slide, please, Layla. Thank you. So the next couple of priorities are looking at 2 areas of young people who tend to be more complex. We have complex young people themselves, and there's a huge amount of work that's already being trialled and piloted across Thames Valley. We're going to look at the Thames Valley Complex Children's Project, rolling out the 24/7 crisis response, which is it's about having an integrated care crisis facility, which would be shared across the partnership, health, social care, with obviously education, I think, also being hugely involved in that. So it's about having a place to go for children and young people for a 24/7 crisis response. But it's also about how do we help young people who are in crisis when they're at home, and what does that model look like, so that we can get them the support where and when they need it. The other area for young people that we're looking at is that transition. And again, some really interesting work is already underway. There's the borderline personality disorder or emotionally unstable personality disorder, and managing emotions training pilots, which are going to be evaluated, and a piloting of the children's ARRS pilot in primary care. Some really interesting work about how we can do more matrix working for that transition, so we don't have a cut-off point, but we work together across the appropriate time frame for each individual young person. Excellent, Lina. Mental health support teams, you'll know that we have been incredibly proud of this. We were one of the trailblazers. We now have 5 teams across Berkshire West. 2 of those are in Reading, and we're continuing to develop this. We recently had our launch. I think it was last week, but it feels like it might have been longer ago than that. And Brian spoke at that for us with the DFE and the Anna Freud Centre. And since that official launch, we've had a huge increase actually in people going onto the local offer and the Brighter Futures website, looking to find out more information about it, which is really exciting. And the mental health support teams are there to promote early intervention and support, and by helping young people, young people develop knowledge and skills for self-care, self-help and resilience really early, we hope that that will then prevent mental health needs from escalating. We've touched on this quite a lot today. Suicide prevention is one of our priorities, and I think it's great timing in the sense that we are all focusing on that this year, and I hope that over the next few months, really, we can have a few workshops where we really pull together and think about the best ways of taking that further, with public health really helping us with that. So the big ticket number, of course, at least in terms of the media, is often about the waiting times for our specialist CAM services and across all our mental health and emotional wellbeing services. So we're working really hard with our CAMS colleagues to decrease their waiting time without increasing the waiting time of the earlier intervention services, such as our primary mental health teams, for instance. There's a lot of almost matrix working across CAMS and our early intervention services, such as primary mental health and number 5, where we work with children and young people who are often on the waiting list for CAMS. We are very proud that the Children in Care or Children Looked After Specialist CAM service is now mobilised. The CAMS team have recruited 50% of the staff needed for that. And that specialist CAM service for Children Looked After is located across Berkshire West, with staff available for each of those 3 local authorities. And already the work they've been doing has had phenomenal feedback. So we're really, really proud of that. And that was a jointly commissioned service. We're expanding the digital offer, and that's going to be exciting to see how that develops, particularly in terms of offering one-to-one support and interventions. As we've mentioned already, looking again at the CAM service specification, we continue to get long-term funding from our ICP colleagues, CCG as it was, which enables us to do a lot of early intervention based in schools, including from primary mental health team, educational psychologists, as well as mental health support team. And excitingly, the CAMS Workforce Academy, we know the challenges of being understaffed across the caring professions. I'm sorry if you can hear my dog whining, be quiet. And the CAMS Workforce Academy is really looking to enable workforce development, which we want to support across the whole system. And we're looking at how we can do that so that people want to stay working within the mental health and emotional wellbeing system in Reading. We've been doing some really interesting work for the next priority, which is about improving inequality in terms of receiving and accessing mental health and emotional wellbeing services. At the moment, we've been doing some work with children who come from Black and ethnic minorities, different racial backgrounds, working with young people in focus groups and parent groups and community services. So that's exciting. Shush. And that's being rolled out to look at other vulnerable groups such as learning disabilities, autism, LGBT. Just quickly on there, I think it's worthwhile just giving a shout out to the mobilisation of the Navigator service for children and young people with LD and autism, and the Dynamic Support Register, and the links to our SEND strategy. That's within Reading, but I know that Wokingham and Berkshire West Berkshire, sorry, are also linking it with their SEND strategy, including the trauma-informed work. Thanks, Anna. Children and young people's eating disorders, you'll be aware that over the lockdown period, that was one of the most complex areas that developed, with high numbers of children and young people presenting with very complex and quite varied eating disorders. And it was a real challenge to the services to meet that demand, as well as to identify that particular need early enough. So our priority this year is to meet the waiting time standards for 95% of children and young people, and the NICE guidelines of 1 week if urgent and within 4 weeks if non-urgent, and particularly looking at the high numbers of children and young people with neurodevelopmental conditions, and putting into place particular programs that support young people who are neurodiverse who have an eating disorder. And then data and digital, I think Layla spoke about this a bit earlier. We want a population health management approach. We want to involve all of our communities, make sure that all of our communities know how and where to access support, including those who may not have English as a first language, use of language so that it's simple and easy to understand for everybody. Looking at our outcomes data, comparing our outcomes data, but also then using that outcomes data to support further service development. For instance, we would like to begin to look at whether or not referrals to CAMS are appropriate. So that number of inappropriate referrals we would ideally see go down as we get that early intervention offer even better. And co-production is our last priority. That doesn't make it the least important, of course. It's really important that we continue to build and develop our services with children, young people and parents. We are showing our commitment to that through the inequalities work, where we are really going out and asking children, parents and communities why they're not accessing the services that we have on offer and what would they want it to look like. Or indeed, what would they want the communications around it to be so it's more accessible for them. There is a date out now for the Berkshire West Youth in Mind Conference, following the one from last year, which was really exciting. Yeah, so I think there are priorities. I'm going to pass you back to Layla.
Let me see if I can come out of this. Have the slides come down?
Yes,
right.
Yeah. Right, thank you both. Did you want to speak there, Ella?
No, I just wonder if there's any questions in the room about the priorities that we've chosen. I think we're hoping that we've sampled widely amongst our stakeholders, and it sort of represents, broadly speaking, what you've already heard this afternoon from other work streams, and it's representative and priorities that we can all sign up to. I think Debs and I are quite excited about the prospect of delivering these priorities, and I know there's other Berkshire Healthcare Trust colleagues in the room that we're working very closely around the transition piece and how we link the children and young people's programs with the developments that are sitting across the adult mental health space, there's also lots of very exciting things happening.
Thank you to both of you. Do we have any questions or comments? Sorry, yeah, Andy.
Hi, it's Dr. Andy Jaczynski here. Just a question. Obviously, providing specialist mental health care is determined by having the staff with the specialist skills to do it. Consultants don't grow on trees, and yet the autism, ADHD waiting lists go up. What's the sort of approach to the workforce issue?
So we have to start to that. Sorry, I've got a bit of an echo going here. There's a Tamina, you may well come in as well from a Berkshire Healthcare perspective. So we have just kicked off a project, a multi-agency project across Bob for ADHD services to think how we can work together and make improvements in terms of waiting times and demand and capacity modelling, and what would it cost to reduce waiting times. In Berkshire West, there is additional funding that has been agreed, again, to be recurrent, to expand the children's pathway around autism diagnosis, and I believe that team is making great strides in employing additional staff. I think by middle of July it was up to 50% increase in staffing, and I think my understanding is that is really on track to delivering, and we are obviously working very closely with Berkshire Healthcare Trust around what that trajectory looks like, and mindful that there are still long waiting times around that. Workforce does continue to be an issue. And I think what we're finding with some of the pilots that we like to run, that it's not the ambitions or the money that's holding us back, it's actually having the staff that can go out and fill those posts for us. I don't know, Tamina, do you want to come in from a Berkshire Healthcare Trust point of view?
Yes, thank you very much. So people who don't know me, I'm Tamina Majmal. I'm the Chief Operating Officer at Berkshire Healthcare Trust. Similarly, have an echo, apologies. We're doing a really significant piece of work around the waiting times for ADHD and for autism in our under 18 cohorts. And I think picking up on what Lila was saying, it's not just about investing money, which has been done. It's making sure, I suppose, a number of things in place. One is, how do we access workforce? How do we look at the people doing which elements of our assessment and diagnosis to make sure we're making the best use of a range of practitioners, not just our doctors, but also our therapists and our nurses as well, who've got a great deal to offer in part of that process. We've already been working for some time with a couple of private providers, Psychiatry UK and Helios. And again, we've been working with them about how we can make the best use of what they can offer specifically, albeit those are online services rather than face-to-face assessments, and focusing the face-to-face assessments on our most complex children and their families to make sure that we can offer them the best assessments possible. You may be aware with autism, the process is to assess for a diagnosis. With ADHD, it often results in titration or medication. So there's always ongoing care for any child who has been assessed with ADHD as requiring medication as well. So it's making sure we're working with all our colleagues for that. And then I guess the other thing is, while people are waiting, how do we put them in touch with their peers for support? How do we make the best use of the support that's available in schools, for example? We've got some lovely examples of really effective community groups in West Berkshire, for example, where we really encourage families and young people to make contact as well. So we're doing a range of different things to try and make the waiters sort of the least painful as possible in terms of making sure things happen while they're waiting, to reduce the waits by varying the range of skill mix we can use to carry out the assessments and working with our private providers. And then, as Lila says, really working hard to encourage people to come and want to work with us in Berkshire.
Thank you. Do we have any other questions or comments? Is there anybody I've missed online? Yes, I think, oh, so is that Dan? Dan, did you want to comment on that?
It is indeed. I just wanted to thank you very much for the presentation. I know we were already connected in so many different ways, but just wanted to re-emphasize the strong commitment to be working along with you on the suicide prevention agenda and those related prevention support and engagement elements. Really looking forward to it.
Yeah, I think we're very excited about this strategy, Dan.
Thank you. Thank you to all of you. That was a really informative presentation. I welcome the refreshed plan and the proposed priorities, which relate to the feedback that you've gained. As this plan is across 2 years, what is your planned approach for keeping the board updated on progress? And also just thinking, what can the board do to support your work?
I should probably answer that. My understanding is that we come back and do sort of fairly regular updates to the health and wellbeing boards across the 3 local authorities as part of this work. I think normally a sort of annual update to keep you abreast of what's happening. In terms of what support you can lend, I think what we probably be looking in the future is how the health and wellbeing boards start working with us around the joint forward plans within BOB, which are partnership plans. So what we obviously want to do is integrate what sits in the health and wellbeing plans, the work we're doing, and how that fits into some of the wider BOB work that we're doing. And I know Debs and myself are working quite hard to make sure that our various strategies and stuff that we're working on are starting to matrix work together much more effectively, which is one of the reasons that I put the SEND strategy on, because we're seeing quite a lot of overlap with the work that happens in the SEND programme, and I think, Brian, you would probably agree with this, is, you know, a number of those children will come into our mental health and our LDA programmes. So we're starting to think much more widely around how we develop our strategies and how we provide services in the widest sense possible. And I think also it takes all of us, actually, these are all our children, to develop that sort of pathway from early emotional well-being to the sort of tier 4 end where somebody might need a hospital bed. And I think, you know, I'm really sensing, I've been here a year now, but sensing that Reading in particular are really very much into integrated working, and it's a delight to be here, and here Dan wants to work with us, and I see Brian's got his hand up as well. So we value the support that we're getting from this meeting.
Thank you very much. Just to finish off then, did you want to, I've got Debs, did you want to say something?
Perhaps if Brian goes first, because it may be in direct response, and then I have a slightly different point. Thanks.
Not wishing, Chair, to turn this too much into a cheerleading celebration at this stage, we are not, as a collective partnership, underestimating the significant challenge we face in terms of recovery for our children, the significant developmental delay that our young people have experienced, and the importance of the emotional health and well-being of our youngsters in the national context. So the National Association of Directors of Children's Services published their Safeguarding Pressures report just before Christmas and identified the significant challenge regarding mental health needs of our youngsters and the gap that was being seen nationally, unfortunately, where NHS-led resources and services were not able to meet the needs, and sometimes areas having to step into gaps. What's so strong about Reading and where we're at in terms of as a partnership right now is I feel confident and I feel optimistic about both the partnership working between the NHS and local authorities, which is strong here, but also the models of delivery. I believe a clinician colleague asked the question about workforce development. We've got some really interesting work we're doing here. So I support and commend the presentation, and I look forward to seeing the impact we can have for our Reading children and young people, and thank Deb and Layla strongly for the work that they've led over this last period.
Thank you, Brian. Did you want to finish off saying something, Debs?
Yes, thanks very much. Earlier in the meeting, one of the colleagues present on the board, and apologies I forget who, suggested that one of the ways we could continue to strengthen and coordinate our work was that if one particular area was doing a piece of work with the community, a presentation, running a workshop, that kind of thing, then could we perhaps invite each other? And I would just reiterate that I think, you know, we're always keen to have a little stall or a little bit in the corner somewhere on children and young people's mental health, just so we continually talk about what is on offer and how to access it. So always happy if anybody is doing anything, if they'd like to drop us an invite to join, that would be lovely. Thank you.
Thank you. Sounds like a very sensible idea, collaborative working. Okay, thank you very much for the really informative presentation. Thank you.
Thank you.
If we move on then, so agenda item 11, which is Reading's all-age autism strategy and action plan, to be presented by Sunny. Hi, Sun.
Thank you, Chair. For those who don't know, I'm...
Sorry, Sunny, would you like to come here? Then you can be on camera.
Okay.
We've got lots of space now, sorry.
Thank you, Chair. For those who don't know, my name is Sunny. I'm one of the assistant directors in adult social care here in Reading Council, and I'm here to present the all-age autism strategy, which has been the year in the making. This is an all-age autism strategy which is being co-produced with autistic people in Reading, their carers, voluntary sector providers, our NHS colleagues and several other organisations. So this very much is a partnership strategy that has been developed. We have been quite thorough. I've been working very closely with my public health colleagues who have been pivotal in supporting me in developing this strategy to make sure that this strategy outlines the gaps in the current provision in Reading and how we as a partnership and a system, we could start to work over the next 3 to 4 years to start plugging those gaps for our autistic residents and their families, and to give them support, not just around adult social care or health or education, but also around employment and the wider the wider system, really. So really, it's making sure that all elements of Reading is accounted for as part of this. And we were very clear, particularly in Reading Council, that colleagues in planning, housing and others were key part of the action plan. So this has been through several iterations and several committees, and it was agreed that given the importance of this strategy, to make sure it was implemented, and often we know there's so many strategies out there, it's quite easy that these can easily sit on the shelf and gather dust, that the strategy did report directly into the Health and Wellbeing Board to ensure that there was ongoing progress and implementation of the key priorities outlined in the papers. The strategy itself would be led by the Autism Partnership Board, which is made up of several stakeholders. And alongside that Autism Partnership Board, and as a result of the work of developing this strategy, is that we're going to develop a reference group made up of people with lived experience, autistic people and their carers. They were very clear that they wanted to be part of service development across the system, and to be making sure that they're driving and informing those services moving forward. So we were very grateful for that offer. And that the board would be ultimately responsible for ensuring that the actions were developed and delivered, and then that the board would write an annual report for that would come to this board every spring-summer on the progress, and also for the board to hold us to account of whether those actions were delivered or not. One thing to be highlighted as part of the strategy, there isn't new monies available to deliver this strategy, so I just wanted to make that clear. So there isn't a pot of money to say, actually, now we can go away. So we were very clear from the onset on that to everyone involved and everyone who contributed to that. But a lot of this was how services could reshape their services and redesign their services, or change their resources to meet the demands that's required. But we also know that ad hoc money does come available throughout the year, and this allows us to say, in Reading we have a strategy and we have a clear plan, and we're able to bid for money if any monies were becoming available. So that gives us certainly an advantage. So yeah, so I didn't want to go into the strategy in great depth, because I know you guys have been here since 2 o'clock. And it's 4:30 on a Friday afternoon, and it's hot in here. But I'm happy to take any questions that you might have around the strategy. One thing I think might be worth mentioning is there's 7 priorities outlined in 3.2.4 of the cover paper. Each priority has a lead agency that is responsible for delivering that. So, for example, improving awareness and understanding of autism is responsibility of the board. And then priority 2 would be our colleagues in BFFC, and then colleagues in employment services, adult social care, housing, our colleagues in the ICB and probation. So it really is a multi-agency led strategy. The other thing, just to let colleagues know, it went to our adult and children's executive on Wednesday night, and it was signed off there. And once hopefully this board is happy, we'll make a nice glossy version of the strategy. So we wanted to make sure everything was happy and all signed and approved before we went, to make sure that that was all ready, so that the final version isn't the version that we will promote on the website, as it were. So yeah, just wanted to outline that, and happy to take any questions.
Thank you very much, Sunny. Alison, you've got a question?
Oh yeah, it wasn't really a question, but maybe a comment. So, and I'll talk a bit about it in talking about the hospital redevelopment, but something that's come up a couple of times in conversations that I think would be quite nice to link into the strategy is how people with autism can influence the built environment. So that's, not just the health environments, but, and there's a lot of development going on in various different places, but certainly in public services, how they influence not just the built environment that's already there, but how they can, from the beginning, be part of design. And so it's something that we're conscious of, but it's great if you've got a board we can link into that can help support the development of any design going forward, because there are things that I never thought existed until I started looking at some of these things, and it's important they're part of the design going forward.
No, that's great, and I think that's the kind of areas that the reference group would really want to get involved in and really feel part of shaping local services. And I think that's where we can start to really engage with this group, which has often been forgotten. So yeah, happy to.
Thank you, Alison. Councillor Ennis.
Yeah, thank you. Again, I very much welcome this strategy, and thanks, Sunny, again for the work and partners. We had a really good discussion on Wednesday night at the Adults, Children's and Education Committee, and a lot what's come out is the health aspects of how we work with our partners linked to this board, but also the autism board, and how we can look at the challenges that people with autism have faced. Whether or not there was automatic referral, which is in the strategy, about referral processes, waiting times, and the transition. And I very much look forward to seeing how that works, because I think we've got the strategy together now, and it's how it's going to work. And that should be a real focus for the Health and Wellbeing Board, and working with our health partners is how we're going to achieve that. So again, I take it's going to be on a regular basis on the agenda, the health and wellbeing, looking at how the action plan, because there's a good action plan included in the strategy, and how we can make progress there, because there's lots of progress that needs to be made. It is a dynamic document, not something to be thanked and then left, which has happened in the past with some strategies, that I've been involved with. I think this time I really feel that we got an opportunity to make a difference. So I would welcome comments from colleagues in health, or on the Health and Wellbeing Board, how we intend on doing that. And now that the strategy has gone through the processes and on its way to agreement. Thank you.
Thank you, Councillor Ennis. If any other comments? Does anybody have missed online? Oh yes, I can see. Sorry, Deb Hunter.
Hi, sorry, just a really quick comment. Thank you. Really, really interesting strategy, one that I know well. And thank you, Councillor Ennis, because I think my comment relates to that. Just in terms of what we're doing in education for children and young people with neurodiversity. So we've got the attention autism, the intensive interaction, and so on. And recently, positive behaviour support was co-commissioned as an assessment and way of helping children, young people who have learning disabilities and or autism. And I just wanted to update the board on what I think is a really good piece of co-production. Some of our parent carers, when they heard that East and Berkshire West had co-commissioned PBS, positive behaviour support, were very anxious that it's based on applied behavioural analysis, ABA, which I don't think any of us sanction, and indeed we have lots of research to show it's harmful. And so we were able to say to our parent carers, we've heard your concerns about PBS and is it based on ABA? And we were able to get a meeting together with some of our colleagues from BHFT, the deliverers of the PBS and the parent carers, to assure them that it's not, although it's based on ABA, it's very, very different, and it's based on a humanist, holistic and empowering approach for our children and young people with autism. So I just thought I'd let you know that we had that meeting last week, really listening to what our parents and carers are telling us and building the way forward together. Thank you.
Thank you. Do we have any other comments? I can see somebody's got a hand up. I'm not sure who it is.
That's still good.
No. Nobody else? Okay. Thank you very much. Have I missed somebody? Oh,
Catherine McDermott, but she's probably getting ready for the next item.
Oh, okay, apologies. Welcome the strategy, so thank you very much, and welcome the ambitious action plan and the partnership involvement, and I'm very pleased that the strategy will be returning to the board so we can monitor progress. So thank you very much. Thank you. So moving on now to agenda item 12, which is the development of the new BHFT mental health strategy. And it's Catherine McDermott presenting.
Yeah, thank you very much. Just a very quick intro. I'm Catherine McDermott. I'm the Director of Strategic Planning for Berkshire Healthcare Trust, so I have the privilege of being in charge of developing the strategies. And I've got some other colleagues here with me today, so we're very happy to try and cover any questions you might have. I'm just going to share the slides. I have shared the slides in the pack, but I have done a little bit of an update, which I thought might be helpful for you to see if I can get it to work. Can you see that?
Yes, you can see. Yeah.
Great. Okay.
It's currently on the original thing rather than on the slideshow. So if you want it to be bigger so everyone can see the full slideshow, you're showing the other slide, the window.
That better?
That's it.
Perfect. Thank you so much for that. I'm not going to take you through each slide because I have shared pack in advance. What I wanted to do was just focus really more on how we're developing the strategy, which gives you an opportunity to say how you would like to be more involved in the development of the strategy. So I'm going to frame it in that way, but I am very happy to take any questions on the developing content as we have now. It is very much draft, so it's a very good time for Health and Wellbeing Board to be able to say we'd love to be involved in that at this particular point in time, and I'm going to take you through some of the opportunities for involvement as we go forward. We have an internal working group, as you would expect, that's made up, and Tamina, who spoke earlier, is obviously key to that. We've done a little bit of a brainstorming so far as to what we think would be important in our new mental health strategy going forward. I used to bring updates to this meeting on the previous strategy, and we made significant progress on a number of key areas, but there were still some areas that we hadn't made as much progress as we had. And then, of course, we've had a pandemic right in the middle of that. And as colleagues have mentioned earlier, that has had a significant impact on people's resilience and mental well-being, emotional health. So we do need to take all of that into account. What we wanted to do was set a vision where we are looking at personalised care across the whole of the age pathway. Now, we do have a separate CAM strategy and we won't be replicating, but obviously it's really important that we make those connections across. We want to do more around thinking of how we develop our clinical leadership and our medical workforce. And people have mentioned earlier about the challenges around workforce. So we want to put BHFT in the place where it is somewhere people really do want to work, because we offer something different. We offer something more over and above other areas. So that we've got a bit of thinking to do around what does that actually mean in terms of our clinical leadership and our medical workforce development. We are going much bigger on partnership working and collaborative working with our voluntary community sector, and I'll come back to that towards the end. At the same time as we're developing this mental health strategy, we're also developing a strategy with our voluntary community sector around how we work together. And one of the key priorities that's come out of that strategy is working together on mental health, and that's around prevention and early intervention and how we can contribute better to community resilience. Urgent care closer to home, there's a lot of work around crisis, a one team approach, and you'll be aware from previous updates the work that's happening with community mental health and our primary care networks. But it's got to be patient centred, not organisational centred, but patient centred. It's got to be about shared care, and it's got to be co-produced. It's got to be community based, although obviously we do provide acute mental health as well. I thought it would be helpful to just set out some of the current pressures that we're facing. And I've already alluded to the fact that, we still have an impact in terms of mental health for the pandemic, for children, young people, and for adults. And I don't think that's going to go away anytime soon. We have massive demands within our acute pathway. So Prospect Park sits within your geographical area, and I know you know it well. This has impacted on the number of inappropriate out of area placements we've had to make. We were doing so well in reducing those, but we need to have another refocus. And the way forward on that is going to be with our partners, to be honest. We're looking at how can we reduce the number of people who are medically fit for discharge within the mental health acute hospitals, but don't have the ongoing support needed to be able to go home. It's exactly the same problem with your physical acute hospitals. Sustainable crisis alternatives, we need to look at demand and capacity within our community mental health services. We have a workshop coming up in a couple of weeks where we're looking at data, which includes our community mental health services. Prevalence of dementia is something we know we need to focus and is in the operational planning guidance. I've learned through a piece of work that I've been leading on for Berks West called the Low Level Mental Health and MDT's flagship priority. There's an amazingly rich, diverse set of services across Berkshire West. That's NHS provided, local authority, voluntary community sector. It's a really rich landscape, but it's quite fragmented. From a patient point of view, it's still a matter of lots of different services, and there's something we can do to really join that up to make it a much simpler and more holistic experience for the people we're looking after. You've heard already demand and capacity pressures in our children and young people services. You heard already the massive impact that COVID's had on eating disorders for children and young people. I know again through the Berkshire West low level mental health priority that there is a lot more we can do around talking therapies and increasing our referral rates into that service, and we have a dedicated action plan in place to help with that now. And then you've already heard about autism by previous colleagues. One underpinning principle that we need to talk to our communities about is the insufficient take-up of early intervention service offers. So what do we need to be doing differently to help people access early intervention services rather than tipping up when they're already in crisis? So that just gives you a little bit of context of the environment that we're currently working within. I thought might be helpful to share. Within BHFT, we have what's called the Mental Health Transformation Board, and I took an update of this strategy there. And there was an ask to include the sort of the current pressures, but a much clearer idea of the journey from where we are, the pressures we're facing, and clarity on how we're going to address those and take those forward. So that will be included in the next version of this strategy. Vision, you've seen this. We're very open to being challenged on this to make sure we get the right vision that the rest of the strategy will hang off. We've put people's well-being as emotional and physical health right at the top of our vision. Developing personalised care co-produced with the individual is right in the heart of our vision. And then, as I've mentioned, something we need to do better and differently, supporting our clinical leadership and workforce is up there in the vision. Aims, I'm not going to talk you through each of those bullet points because you've already had those. I haven't changed them. The work that we've done today has sort of directed us towards 10 key priority areas. So you can see that data and population health management, demand and capacity is one of those areas we need to get into. You can see that clinical leadership, driving and leading care is another area. Pathway development will always be a priority for us going forward. People, our team, one team, roles and responsibilities, staff wellbeing continues to be a key priority. See ASD and comorbidity prevention, efficient working. I would hope that you recognise all of those areas as key priority areas. And I guess my challenge is to you, do you think there's anything that we've missed in that? Because you will have a different lens on this. It would be great to know if you think there's something else you would have expected to see. What I've done in the next few slides is, rather than talk about what we will do, so your inputs, I've tried to create an output perspective. We obviously will need to have an implementation plan that clearly says, you know, we will do X by X period in time. But at this stage, I wanted us to focus more on what do we want to achieve? What are the outcomes for our patients that we want this strategy to help us drive? So we've got, in terms of community mental health, a one team multidisciplinary team approach based with our primary care networks, much more integrated with our voluntary community sector partners, working in collaboration across BOB so we can maximise the efficiency. Alternative provision for those in crisis that we've talked about. We've done really well in terms of our physical health for people with serious mental illness, and we'll continue to drive that forward. Children and young people, you've had a few conversations around that earlier. It's one of the priorities for BHFT on the East Berkshire side, where we're working with Frimley and Surrey and Borders to transform the eating disorder services. Any learning from that will obviously impact on children from the West Berkshire side. Learning disabilities and autism remains a key priority area. Improved dementia care, access and waiting times. As I say, we have a workshop in a couple of weeks. So where I've got reducing waiting times in X, we will actually list those key areas that we want to look at. Eliminating out of area placements. Again, we come back to that priority. And then reducing health inequalities will be a new area in our mental health strategy. We already have a dedicated programme of work around the Mental Health Act detentions programme. And part of that workshop in a couple of weeks will highlight other areas within mental health services that we would want to focus some attention on to make a difference in outcomes for patients. A strategy wouldn't work without being able to be really explicit on what we need in place to make it work. So data, population health management is key. Co-production in terms of how we take this forward is absolutely totally key. And of course, our people, our workforce, we can't deliver anything without our workforce. But there are also some opportunities in terms of digital and working smarter that should be able to help us be more efficient, so spend more of our time patient facing rather than doing back office functions. This is where I really wanted to make sure I shared with you. So what are we doing next? We're running a series. I'm currently in negotiation with the CVSs across Berkshire. We'll be running a series of engagements events with our voluntary community sector, with our CVSs across Berkshire throughout 23-24. And I know that some of those areas will include mental health services, access, outcomes. So they will be running through 23-24, and it will be fantastic to have some of your input into those. As I've mentioned, we have a health inequalities workshop in 2 weeks that's looking at data, which does include mental health weights and outcomes. I'm currently negotiating with Mind to commission them to support our community engagement work in for the Mental Health Act detentions programme of work that we're doing. I've led on a Berkshire's flagship priority on low-level mental health, which has been really interesting and really fascinating. We now have, it's called a geospatial maps. It's a web-based map which can show you where all of the talking therapy services, the voluntary community sector services, local authority services are. across Berkshire, and it allows you to filter by ethnicity, by age, by geographical area. So I would really encourage people to use that as a planning tool in terms of mental health going forward. Bob's just established its mental health partnership, which is really fantastic and enables us to work across. And as I've mentioned, we've been developing a voluntary community sector strategy at the same time. And what I've done here is pull out the two key areas that really overlap between the two. So the focus on children and young people, physical and mental health, working with communities and schools, co-producing processes that better support early identification of people, young people in need. And then in terms of adult mental health and emotional well-being, going much bigger on working with our local communities, voluntary sector and diverse groups to rebuild mental well-being and to tackle the stigma of poor mental health. And then just really finally, this is the NHS and we're into operational planning mode. So I thought it might be interesting for you to see the key elements within the operational plan that BHFT will be committing to as part of developing the operational plan. So it continues to focus on community mental health integration with primary care networks, which is exactly what we want to do. Increasing access for children, young people and CAMS services, which has been highlighted. Increasing referrals to talking therapy services, which we already have an action plan in place to do. Increasing support for adults from our community mental health teams. Eliminating inappropriate out-of-area placements. Focus on dementia and improved access to perinatal mental health services. So that's a quick gallop through. I know I can talk fast. I'm very happy to take any comments and questions. I'm very happy to take any challenge on the outcomes or the vision that we set out, but I'm particularly interested in how you'd like to be involved in the development of the strategy going forward. And I've given you just some of the opportunities that you may be interested in engaging with. So I'm going to stop there and see if there's any comments or questions. Thank you.
Thank you very much there, Catherine. I see we've got a hand raised there. Is that a question from Deb Hunter?
Hello. Thank you very much, Catherine. Really, really interesting to have read the slides and hear you go through them. I'd be really keen to help be involved in any workshops you have with the voluntary sector, particularly around children and young people's mental health in schools and the community. Thank you very much. Great.
Oh, pardon me, I didn't have my mic on. Do you want to, should we take a few questions and you can respond to them at once? So I don't, was it Alice? Yeah,
Yes.
next.
Hi, Catherine. I'm Alice Clifton, lead officer for Health Watch Reading. One of the things I'm very, when we do feedbacks and things, one of the things people say is they don't understand how to access services. The language that we use